The committee will come to order. Good morning. We are meeting today to mark up two key pieces of healthcare legislation to advance the committee's long-standing work to improve the access, quality, and affordability of healthcare for the American people. On the docket for today is the Healthcare Price Transparency Act of 2023. This legislation builds on and expands existing efforts to provide patients and families greater insight into the actual cost of the care they receive, spreading that transparency to every corner of our healthcare system, from hospital services to laboratory services and imaging services to insurers and pharmacies and more. And we are utilizing that transparency to inject greater competition into our healthcare system to lower prices. The idea that underpins these policies is simple, but critically important. Patients have the right to know what they will owe for the medical services they receive before they receive that care. Most transparency also means more accountability. Our healthcare system has seen tremendous consolidation over the past several decades. This has led to credible concerns that providers may have a financial incentive in directing where their patients receive care, rather than what is in the best interest of the patient. This bill will take efforts to address this all too common practice while lowering cost for patients. Also before us today is the Providers and Payers Compete Act that requires CMS, the largest healthcare payer in America, to examine how its Medicare rules and innovation models affect healthcare consolidation. I'll have more to say as we move to consideration of the Healthcare Price Transparency Act, but let me just close here by noting that the policies before us today truly reflect bipartisan priorities of greater transparency in healthcare and lower costs for patients. We have been working with our Democrat colleagues for months on these policies, and while we may not agree on everything, I hope those bipartisan efforts will continue even after today's markup. I'm now pleased to recognize the ranking member from Massachusetts, Mr. Nill, for his opening statement.
Thank you, Mr. Chairman, and I would agree that there was an opportunity here for bipartisanship, but I think we ought to reference that in the past tense. As we stare down the August district work period, it's disappointing to imagine what could have been. We have shared goals here and good faith negotiations that could have led to significant progress for all members of the American family. Our colleagues wanted to allow forces outside the committee to prevail, and now the legislation in front of us should be described as a missed opportunity for bipartisan action on promoting healthcare transparency. We came to the table in hopes of a deal with one basic request: improve on what Energy and Commerce Committee members had produced and fill in the gaps where they left out critical pieces. Unfortunately, the legislation here today does neither. Certainly, Democrats are in favor of safeguarding consumers, and our recent record shows that. We bolstered patient protections in the Affordable Care Act, and now, thanks to those Democratic investments, more Americans are covered than ever before. We've repeatedly acted to protect Medicare and its life-saving care opportunities that it provides to millions of America's seniors. Democrats reduced drug prices and put money back in the pockets of millions of Americans with the landmark Inflation Reduction Act. Clearly, our work is not done. It's impossible to talk about transparency in the healthcare system without talking about private equity, which isn't addressed in this legislation. Its unchecked expansion across the industry has been tied to patient outcomes, higher mortality rates in nursing homes, hospital bankruptcies, closures, surprise medical billing, and other parts of Medicare fraudulent practices. Patients have no indication of how PE ownership affects their care, nor can regulators conduct proper oversight. Congress should and must find ways to ensure greater accountability of owners to protect patients and make certain they receive quality, affordable care that they deserve. Another area of disagreement with our colleagues insisting on transparency standards based on age. One of the key gaps in the product is the failure to apply the same standards to Medicare Advantage, which covers 30 million Americans and will spend more than $9 trillion over the coming decade. So while it's laudable that our colleagues want to give my 64-year-old constituents more information on their plan, once they turn 65, they no longer deserve the same background on their Medicare Advantage plans? The omission is concerning. It shouldn't depend on your age. All consumers deserve the same transparent information from their health care plans. Other opportunities for stronger healthcare industry oversight were left on the table today. increasing consolidation with insurers, pharmacy benefit managers, and providers, which we know has led to more opaque marketplace outcomes. They need an infusion of sunlight to promote better competition. Democrats won't waver in our efforts to help make informed decisions about their health care. Workers and families must be able to understand that health care insurance options available to them should be readily transparent and rely on robust oversight that prevents anti-competitive tactics and then protects consumers. Unfortunately, the legislation before us today misses an opportunity to strengthen these safeguards. Let me underline something. Democrats wanted an agreement on this legislation, and 10 days ago, we thought we were going to get it. We could have mitigated these issues and promoted transparency across a wider spectrum of healthcare industry opportunities. We could have protected consumers and further ensuring that they have the information they need to access quality, affordable health care, and we could have and should have worked together. Thank you, Mr. Chairman. I yield back my time.
Thank you. Our first order of business is H.R. 4822, the Healthcare Price Transparency Act of 2023. For decades, healthcare inflation has far outpaced normal cost increases for most other services. Many people now spend the biggest portion of their income on healthcare. While costs continue to rise, our system makes it nearly impossible for patients to figure out the actual price for almost any type of treatment, drug, or procedure. The Healthcare Price Transparency Act of 2023 is a win for patients who deserve to know the actual price they will pay before they go see the doctor, fill a prescription, or get an x-ray. Families should not have to live at the mercy of large medical corporations who are too ashamed to list their prices publicly. This bill is about bringing honesty and clarity to the cost of healthcare. It improves a Trump administration rule requiring hospitals to publish prices for the medical services they provide and extends this meaningful transparency to other sites of service, including ambulatory surgical centers and providers of imaging and laboratory services. Importantly, the bill holds the administration accountable for enforcing these requirements. At a Ways and Means hearing in May, we heard that of the more than 6,000 hospitals in America, as many as 75% are non-compliant with the rule, yet only 4 have been fined for not complying. Clearly, Congress needs to do more to ensure meaningful price transparency reaches patients. This legislation will also require transparency for health insurers and PBM middlemen so that patients and employers can better understand how their benefits are managed. Unleashing this important information will spur competition and lower prices across the entire healthcare system. At another Ways and Means hearing this spring, the committee learned about Medicare patients facing higher out-of-pocket cost for the exact same medical service, just because a hospital's name is on the door. Today, we take a step forward in ending this nonsensical practice, directly lowering the cost seniors pay for expensive drug services like chemotherapy, while preventing facilities from using billing loopholes to charge taxpayers a higher price. More and more, a patient's doctor, health insurer, PBM, and pharmacy could all be owned by the same parent company. This is especially true in Medicare. Taxpayers deserve to know that seniors on Medicare are receiving services because it's good for their health, not because it's good for the financial health of a very large company. Additionally, under this bill, seniors on Medicare Part D and Medicare Advantage will no longer be charged more for a drug than the price their insurer pays. I know my colleagues across the aisle share in our goal of lowering the cost of medications, particularly for America's seniors, and so I hope they'll join us in advancing this key patient protection. This legislation also reinvests savings into an important bipartisan priority for all members here today, improving the prior authorization process for seniors on Medicare Advantage. While we are glad to see the administration issue a proposed rule last year, we want to send a clear message that Congress is pushing for the rule to be finalized so patients and their doctors can better decide when they receive care. For families, paying for their health care can be a real source of anxiety. Through this legislation, we can give patients the confidence of knowing what they will pay for their health care while creating incentives for everyone in the healthcare system to lower prices. I will now recognize the gentleman from Texas, Mr. Doggett, for his opening statement.
Thank you very much, Mr. Chairman. Once again, the name of this bill, Healthcare Price Transparency Act, is betrayed by its contents. The primary purpose today is not more transparency, but less transparency. What could have been a meaningful bipartisan product advancing new policies and strengthening prior work has instead become a partisan effort to weaken and dismantle legislation that has already been approved unanimously. Every Democrat and Republican in attendance at the Energy and Commerce Committee voting for a piece of legislation. Today's markup and the proposal that is out here doesn't take us a step forward to give consumers more information. It begins to take a step back from the standard that has already been established in the Commerce Committee legislation. Increasingly, healthcare consolidation combined with flawed system design and policies that sanction monopolistic behavior is failing patients across the healthcare system. Prices go up year after year above the cost of living growth, emergency room wait times lengthen, doctors' offices close, and quality of care suffers. The bill before us essentially codifies what is already required of hospitals and some insurers. Meanwhile, some of the worst actors are shielded from any meaningful accountability. Once again, Medicare Advantage is given special treatment by this bill, omitted from the transparency requirements of today's legislation. Charging over $1,500 more per person each year than would otherwise have been spent by taxpayers if the patient were in traditional Medicare, private insurers are making huge profits off Medicare Advantage. This bill continues to advantage those private insurance executives over disadvantaged healthcare consumers and American taxpayers. And this legislation completely ignores the growing impact of private equity with its rapid takeover of so many healthcare sectors, often resulting in increased costs and worsening health inequities. Despite modest, bipartisan, unanimous approval of measures to address both Medicare Advantage and private equity in the Commerce Committee, today's legislation is silent, completely silent about doing what's needed on Medicare Advantage and on private equity. Transparency can lead to better oversight, but only if it is targeted toward the right information and the right actors and is paired with enforcement. Unfortunately, this markup misses the mark in addressing these issues and offers very little toward lowering outrageous prices. Nor does this legislation do anything to provide better transparency into the pharmaceutical industry, let alone reduce price gouging or even record the enormous contributions that taxpayers make as angel investors in research and development. American taxpayers today are the single largest contributors to pharmaceutical research and development in the world, and they're also being charged some of the highest prices for what they paid to develop. We all want to encourage cures and treatments for dreaded diseases long before we or a loved one face a troubling diagnosis. Today would have been an opportunity to strengthen, not weaken, the Commerce draft by getting more information about pharmaceutical monopolies and oligopolies that have been concerned with manipulating the system to delay competition and extract the highest prices that the sick and dying will pay rather than to create more innovative treatments. Over the decade, 78% of new drug patents were not for new cures, but were small modifications to existing drugs designed to extend monopoly power and charge Americans monopoly prices. By one new estimate, about $40 billion in taxpayer dollars were wasted in 2019 alone on drugs that violated laws regarding competition. 30% of Americans, about a third of our country, report not picking up prescriptions or skipping doses because they couldn't afford the medications. Nothing in this bill will help the half of Americans who cannot afford a $500 emergency. While consumers get sticker shock and medical debt, corporate interests get a shield from meaningful action with regard to private equity. Moving forward, what we need is bipartisan action to lower prices, not just bigger font when prices are disclosed. I yield back.
Thank you. The committee will now proceed to consideration of H.R. 4822, the Healthcare Price Transparency Act of 2023. Without objection, the measure will be considered as read and open for amendment at any point. And at this time, I offer an amendment in the nature of a substitute, which was distributed in advance along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for purpose of amendment. I will now turn to Matthew Mumma, Legislation Counsel for the Joint Committee on Taxation, to provide the technical description of the tax provisions in the amendment in the nature of a substitute with an emphasis on the changes made since introduction. I ask that members hold their questions until after his presentation.
Thank you, Mr. Chairman and Ranking Member Neal. The committee members have before them a document JCX 3623, which describes the tax provisions of the legislation, as well as the Ways and Means description of the Chairman's amendment in the nature of a substitute. For some quick background, this legislation largely codifies 2020 regulations issued by the Department of the Treasury, Health and Human Services, and Labor, which will require group health plans and health insurance issuers of group and individual coverage to allow plan participants to use a self-service tool to gain information about the coverage available under their plans. It also requires these plans and issuers to make publicly available 3 machine-readable files, which would include in-network rate information, out-of-network cost information, and prescription drug information. This provision of the legislation would go into effect for plan years beginning on or after the date that is 2 years after the date of enactment, and JCT and CBO economists estimate it will have no revenue effect over the scoring window. The second tax provision of this legislation includes oversight of pharmacy benefits manager services. Pharmacy benefit managers, or PBMs, are third-party administrators that manage prescription drug benefits for group health plans and health insurance issuers. PBMs typically process prescription drug claims, maintain formularies, and negotiate contracts with drug manufacturers. This legislation will require plans and issuers of group health plans to release to plan sponsors annually a report about PBM services. This report would include information about co-payment assistance available to participants in these plans, a list of each drug covered by the plan dispensed during the year, including detailed cost information, a list of each therapeutic category class of drugs dispensed during the year, including detailed cost information, total gross spending and total net spending information, and information about relationships between the PBM and other third parties, including consultants, advisors, and drug manufacturers. This legislation would go into effect for plan years beginning on the date that is 3 years after the date of enactment, and a score is pending from CBO. The Chairman's amendment in the nature of a substitute for the tax legislation makes technical corrections so the bill works as intended. And I'm happy to answer questions after the presentation.
Thank you. I will now turn to Patrick Dumas, Staff Director for the Health Subcommittee, to provide the technical description of the health provisions of the amendment in the nature of a substitute with an emphasis on the changes made since introduction. I ask that members hold their questions until after his presentation.
Thank you, Chairman Smith, Ranking Member Neal. H.R. 4822, the Healthcare Price Transparency Act of 2023, contains multiple provisions to promote healthcare price transparency, encourage competition, lower costs, and make the healthcare system work better for patients. Section 101 amends Part E of Title 18 of the Social Security Act to require certain medical providers to publicly disclose pricing information. Hospitals and ambulatory surgical centers would be required to post information in both a machine-readable file and a consumer-friendly price estimator tool. Clinical laboratories and providers of specified imaging services would be required to publish cash prices, and all providers would be subject to civil monetary penalties if deemed non-compliant. The amendment in the nature of a substitute extends the effective date for certain requirements of this section. Section 104 requires the Government Accountability Office to report on existing and new healthcare price transparency requirements. their compliance, enforcement, patient utilization, and whether requirements can be harmonized to reduce burden and as well as extend to additional sites of care. Section 105 amends Section 1857C of the Social Security Act to require Medicare Advantage organizations to report to the Department of Health and Human Services certain information related to healthcare providers, pharmacy benefit managers, or PBMs, and pharmacies with which they share common ownership. The section further amends Part E of Title 18 of the Social Security Act to require the Medicare Payment Advisory Commission, or MedPAC, to study and report on vertical integration between Medicare Advantage organizations, healthcare providers, PBMs, and pharmacies, and how it impacts beneficiary access, cost, quality, and outcomes. Section 201 amends Section 1860D2 of the Social Security Act to require prescription drug plans under Medicare Part D to limit post-deductible beneficiary cost sharing for prescription drugs to no more than the net price of a drug. This section also requires the Government Accountability Office to report on the compliance of this provision. Section 202 requires off-campus hospital outpatient departments to obtain and use separate, unique national provider identifiers for the purposes of billing Medicare. Additionally, this section requires the Inspector General of the Department of Health and Human Services to submit a report to Congress on the compliance of a previous Medicare payment revision and recommendations for how to improve compliance. Section 203 amends Section 1833T16 of the Social Security Act to require off-campus hospital outpatient departments to be reimbursed for the administration of certain physician-administered drugs at the same rate as the Medicare physician fee schedule. This policy will be phased in over 4 years, beginning in 2025, with an additional 1-year delay for off-campus hospital outpatient departments located in rural or health professional shortage areas, or certain cancer hospitals that are exempt from the traditional Medicare billing schedules. Section 301 amends Section 1852 of the Social Security Act to require Medicare Advantage plans imposing prior authorization requirements to establish an electronic prior authorization process, as well as provide real-time decisions on such requests for patients and medical providers. Additionally, this section requires Medicare Advantage plans to report information relating to prior authorization approvals and denials, and requires various entities to submit analytical reports to Congress. The amendment in the nature of a substitute provides funding for the implementation of this section. Section 301 amends Section 251A6D of the Balanced Budget and Emergency Deficit Control Act of 1985 to, in year 2032, extend the Medicare sequester for an additional 2 months at a rate of 1.5%. This concludes the technical walkthrough, and I look forward to answering any questions you may have.
Thank you. Are there any technical questions about the amendment in the nature of a substitute? Mr. Doggett is recognized for technical questions.
Mr. Dumas, I'd like to get a better understanding of Section 201 that you just referenced, but as you turn there, one thing we can reach complete agreement on is that there is nothing in that section or any other section of this bill that will impose any duty on a pharmaceutical manufacturer.
Section 201 would require Medicare beneficiaries receiving prescription drug benefits under Medicare Part D or Medicare Advantage plans to not have cost sharing in excess of the net price.
I want to ask you about that, but just before we get there, can't we agree that neither that section nor any other section imposes any duty on a pharmaceutical manufacturer?
Section 103, which deals with pharmaceutical benefit managers reporting information to plan sponsors or employers, does require some information relating to pharmaceutical manufacturer reporting, in which case the manufacturers may have to provide such information.
All right, indirectly, but it does not require a pharmaceutical company to do anything about the price it charges.
Section 103 would require pharmacy benefit managers, if able to obtain this certain information relating to prices and copay assistance.
The duty is on the pharmaceutical benefit manager, not on the pharmaceutical manufacturer.
To obtain the information from the pharmaceutical manufacturer.
There's really no reason to believe that the third of Americans who cannot afford their drugs now are going to see the price that they pay for drugs lowered by a penny, is there?
I'm sorry, is there a,
There's no reason to believe that this legislation is going to lower drug prices.
Mr. Doggett, please refer to technical questions for the witness.
Is there anything technically in this bill that would cause Americans to be able to get lower drug prices?
Section 103, the PBM reporting provision?
They can get a report about how they're being gouged by prices. Well, let me go specifically into Section 201 and try to understand what is a fairly confusing section. As I read, the goal is to say that a beneficiary's cost sharing can't be more than the average net price. I think that's what you said. And my concern is, don't the prices of drugs vary within a year so that they go up and they mainly go up, but they can fluctuate within the year?
For certain drugs, that is correct.
So if I've got a constituent down in Austin that goes into the pharmacy this month for a drug, how does a plan calculate what the average net price for the entirety of 2023 is in the middle of the year?
Through conversations with stakeholders such as plan sponsors and pharmacy benefit managers administering such benefits on behalf of the plans, they have identified that they would be able to establish processes to ensure that this protection would work throughout a year, and if it can't be done in real time, they may find ways to adjudicate at the end of a plan year.
Well, would they basically have to guess in the middle of the year what the price will be at the end of the year, how much more the pharmaceutical manufacturers jack the price up?
According to this legislation, that would be up to the plan sponsor and PBM to decide, and there is a compliance provision for the Government Accountability Office to study such.
What happens if the plan guesses or estimates the average net price incorrectly and the cost of the drug went up or down significantly? Is there anything in the legislation itself that assures that the patient will get any refund if that happens?
The legislation does prohibit plan sponsors from charging patients cost sharing in excess of the net price of a drug. So if that net price were to change, then it would be on the plan sponsor to ensure that that is adjudicated.
Would that lead to a refund to the patient in that unusual situation?
CMS, the Centers for Medicare and Medicaid Services, that would implement the provisions of this section would develop guidance for how that would be adjudicated.
Let me ask you about that. Has the Center for Medicare and Medicaid Services indicated that this provision can even be implemented the way it's been written?
There were multiple calls with the agency to provide technical assistance on this section, as well as with industry stakeholders such as the plan sponsors themselves, and the general consensus is that this provision can be implemented.
I understand that you've talked to them, but they have not indicated, have they, that they can effectively implement a system that involves so much guesswork?
I wouldn't want to speak completely on behalf of the centers for that. They did provide technical assistance on this bill.
Very important to know whether what's been written here can actually be implemented and even provide the very modest benefits that the chairman claims it will provide. I yield back, Mr. Chairman.
Are there any additional technical questions on the amendment in the nature of a substitute? Seeing none, we'll move to strike the last word. Does anyone wish to strike the last word? Mr. Buchanan is recognized to strike the last word.
I'd like to strike the last word. Thank you, Mr. Chairman. I'm glad we're holding this important markup today to build on work done by Speaker McCarthy's Healthy Future Task Force and Energy and Commerce Committee. The issues that we're tackling today are just the first step in bringing more transparency to healthcare marketplace and reducing healthcare costs for our constituents. I had a meeting this week with a lot of small business owners and individuals. What's happened with the cost, and not just small business, but individuals, is a disaster. That's why so many people are living week to week, because they're having to come many times $100, $200 out of pocket each week. So this is something we need to work together more aggressively on in terms of bipartisanship, for sure. The Trump administration laid the groundwork in 2019 with transparency rules for hospitals and insurance companies to help everyday Americans know that what they're paying for a procedure, even if it's at a different facility. Unfortunately, since then, some estimates show that about 25% of hospitals are complying, which is unacceptable. I can't imagine why that is, but some people don't even think it's 25%. Today's bill will codify these rules and increase penalties that CMS can issue for noncompliance. Codifying these rules was one of the recommendations made by the Healthy Future Task Force that I co-chaired. And I'm glad to see this as a part of the committee's markup today. Finally, I'm happy to see the improving senior timely access to CARE Act, including as a section of the bill we're marking up today. We marked this bill up on its own last fall, and it passed through the House but didn't get through the Senate. Hopefully we'll get this done this time and get it over, work something out with the Senate. With this bill, we have an opportunity to make a meaningful impact on reducing prior authorization burdening Medicare Advantage enrollees face each year. This bill has broad bipartisan support with 326 bipartisan co-sponsors last Congress. Over 50% of Medicare-age seniors are enrolled in the MA plan for 2023. It's past time that we get together and get this bill on the President's desk. Today's markup is a great start, but there's still a lot of work that need to be done. Our constituents deserve access to affordable health care, and they need it now, and removing unnecessary barriers while increasing transparency is a great foundation to build upon. I look forward to supporting this bill in today's markup, and with that, I yield back.
Thank you. Mr. Larson is recognized to strike the last word.
Thank you, Mr. Chairman, and I want to associate myself with the remarks of Mr. Neal from Massachusetts, and I feel badly for a lot of our colleagues and friends on this committee who work in good faith and have strived their best to come up with what everybody thought was a compromise and working together on a bipartisan basis. Apparently that view was not shared by Mr. McCarthy and the 25 who have other purposes, and especially and most glaringly, as Mr. Doggett articulated, the private equity issue here is just verboten. To be in a situation where private equity, and Mr. Chairman, I'd like to submit for the record 3 major studies that have gone on with regard to the impact of private equity purchases of health care on patients, which is our final goal.
Without objection.
Thank you, Mr. Chairman. The reason that we do that is, again, to point out, as Mr. Neal did, how close we were to having a bipartisan deal that would actually have a direct impact. There undoubtedly are some good things in this bill, I think, that people would like to acknowledge. But when it becomes ruined and tainted by private equity being able to come in, now the only reason they're purchasing these healthcare organizations is to make a profit. There's nothing wrong with making a profit. But what's wrong, and I think everybody on the committee knows this, is when that profit comes at the expense of patients. Undoubtedly, everyone on this committee is striving to make sure that Americans have the best health care system that's affordable. But it's how do you conceive that is even possible when we look the other way at what private equity companies are doing and how they're destroying a system. So all the goodwill that's been built up, all the hard work and effort is thrown overboard so that private equity firms can come in, buy up these healthcare organizations, and then hurt the very patients that we're trying to help in this process. That is my concern, Mr. Chairman, and especially with the limited amount of time we have left before we go on break. And again, I feel badly because of the people on both sides who were working in earnest, but this is a bridge too far. And to turn this over and acknowledge that, no, what we're going to do here is allow private equity firms to continue to gouge the public is just unconscionable. And with that, I yield back.
Mr. Smith is recognized to strike the last word.
Thank you, Mr. Chairman. I appreciate this opportunity. This is important work we are doing on transparency and competition, true competition in the healthcare industry. As we discussed in committee hearings earlier this year, this transparency is important. Our constituents, both patients and employers, need access to the information necessary to make informed choices about their health care and their coverage. We must also ensure the efforts we take here are actually creating, increasing access to care and decreasing health care spending. Very important. I believe this bill will achieve that, and I'm pleased it also makes important improvements to proposals that have been taken up by other committees as well. As I've said before, moving too quickly with technical or complex legislation can have unintended consequences. Over the last few weeks, committee discussions have helped us identify ways to address impacts on rural and underserved areas. We have worked hard to include flexibilities in this legislation, such as extra implementation time for rural and health professional shortage areas. I'm also very pleased to see some of the savings created by this legislation will be invested back into our healthcare system through the passage of the Improving Seniors Timely Access to Care Act. This long overdue effort to improve Medicare Advantage prior authorization process will modernize and expedite the process of frequent concern raised by providers across my district. Again, I appreciate that we are addressing these important issues today and hope that all of my colleagues will support this bill. It's important work. I yield back the balance of my time.
Mr. Blumenauer is recognized to strike the last word.
Thank you, Mr. Chairman. I appreciate the comments that we've heard to date from people on both sides talking about the complexity and the nuance. But I'm concerned that the legislation falls short on the mark. No one is against increased transparency when we're talking about health care. Everyone knows that it's complicated, opaque, with patients only realizing what they're responsible for too often after the fact. This committee has previously worked in a bipartisan manner to protect consumers by enacting legislation to fight supplies billing, and I was hopeful that we'd be able to do the same as we embark today. But I'm afraid we're taking up a proposal that simply is woefully inadequate. To be clear, patients should have access to more information about the services they're accessing, particularly if they're bearing the financial burden. But this transparency should be coupled with resources that will help them make sense of the information they're getting and should be widely applied. I've been a strong supporter of Medicare Advantage, as I think is known by everybody on this committee. I think there's tremendous potential, it serves many people, and there are opportunities for innovation. But they who are Medicare Advantage participants should be protected by the transparency requirements that other private insurers have to follow. There's no reason to exempt them. Half of all Medicare beneficiaries enrolled in Medicare Advantage, this appears to be a missed opportunity to protect them. But I agree that the most glaring omission is a lack of attention to private equity. We all know that private equity is playing more of a role in the healthcare, buying up practices right and left, and some of the effects of what they've done is deeply alarming. An estimated $750 billion has been spent in the last decade on private equity-backed healthcare deals. And these companies, I mean, the pattern is clear. They operate facilities with less staff. You know that from experience in your own district. They have other cost-cutting measures, and then they turn around and sell them in a relatively short period of time, 4 to 7 years. That's not a model that's committed to improving the health of a community. It's a model that's improving the status of shareholders. There have been numerous reports about how companies have been impacted by the explosion of private equity, including an investigation by CBS News detailing companies that rapidly buy and close hospitals, leaving patients stranded. Backing healthcare providers with private equity means they're beholden to shareholders, not patients. This is readily apparent time after time. If we want to address the cost of healthcare and quality and the effects of consolidation, I don't know how we do that without increased transparency around private equity ownership. Just transparency about it. I think we should probably do far more than that, but we ought to start with transparency. We have an opportunity to make difference for patients with increased transparency, but I don't think we let this moment pass without addressing the real challenges our healthcare system is facing, including Medicare Advantage and especially private equity. And I yield back.
Mr. Kelly is recognized to strike the last word.
Thanks, Chairman. I'd like to, if I can, for the record, present two articles, one from the Wall Street Journal and the other the New York Times, for the record, talking about the delays that are taking place right now and the effect that it has. First of all, I want to thank Ms. Delbaney. She and I have been working on this for quite some time. And I think that when we talk about our seniors, the people who paid the greatest price, made the greatest contributions to the country over their lifetime, it's a shame that at their end, they have to wait so long to get authorization for something that they've actually earned. It's become too complicated. And oftentimes, I've said this, you know, when looking at your life as an hourglass, when you're running out of sand, it's a little bit too late to start worrying about what should have been taking place earlier. And I'm glad that the committee's focusing on this now to ensure the highest quality, most affordable health care is possible for our fellow Americans. I've got to tell you, the last Congress, Ms. Delbaney will remember this too, we had 326 House co-sponsors, 52 Senate co-sponsors, and over 500 organizations and endorsements. And it passed Ways and Means Committee unanimously, and finally unanimously passed on the floor. So I'm thrilled that it's included in the 118th Congress. But I just want to go back to, if we can just stay on policy and not get caught up in the political end of all this, it's amazing how much more we can accomplish. And I've got to tell you, I understand that the concern about us not addressing this and maybe not having enough information on it. I would go back to the last session and think that, well, if it were so easy and so possible, if you have the House, you have the Senate, and you have the presidency, a lot of the things that you find fault for us not doing, my question is, what's the holdup, gang? Why the delay? Why all of a sudden have we found out that the real enemy for the American people is not some outside influence, it's the internal conflict that we have. I love the term "we need to work together," which is usually trumpeted by the majority, and then the minority sits and waits and says, you know, it would have been nice if you had included us. We would have liked to actually weighed in, and some of our amendments would have been germane. It would have been nice to hear all that. But when you wait to the last minute and it can affect the total cost of a bill, that's the time to wonder about, okay, listen, if we are sincere in what it is that we're doing, and I believe we are sincere on both sides, my request would be to take off your red shirt or your blue shirt and look at policy that actually is beneficial to our constituents. You know, they don't see us that way. They see us as people they like or people they don't like, people who want to help them, people who don't want to help them. And we trumpet it all the time. We constantly tell them, listen, you can't trust those SOBs on the other side because they really are trying to take advantage of you. And I talk this way because this has been my whole life. There's nothing more costly than something being put off. The cost increases. Sometimes you don't even get a chance to see what the total effect is because the people are no longer there that are waiting for the care. We have an opportunity to do something today, and I would hope that when we use this term, we need to learn how to work together. We need to actually get together and do things that are in the right interest for the American people. I would hope that we can start, to thinking that way, and again, I mean this sincerely. I'm in the retail automobile business. I've never asked anybody, if you're a Republican, I'll give you a discount. If you're a Democrat, you're going to have to pay over a sticker. I mean, it's just absolutely ridiculous. Nobody does those things in the private sector, but the private sector really depends on success, right? We have an opportunity to do something today. I would hope that we do the right thing for the right reasons and we'll get the right results. So I want to yield back, Mr. Chairman, but I thank you so much for bringing this forward, and to my colleagues. We're all in this together. Let's make sure at the end of the day the American people win. Thank you so much, and I yield back.
Mr. Thompson is recognized to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word. And I too am pleased that the committee is advancing legislation to improve transparency in our healthcare system. I've long been frustrated that in healthcare, and only in healthcare, is it impossible to know what something's going to cost before you buy it. I know personally how infuriating this can be. I'm also generally supportive of the reforms to prior authorization that are included in this markup, and I'm grateful to Ms. Delbaney for her long work on this issue. Thank you. Unfortunately, today's markup, in keeping with much of this committee's work over the past 8 months, strikes me as needlessly partisan. We had an opportunity here for meaningful bipartisan legislation, and contrary to my friend from Pennsylvania, we didn't slow walk our efforts. We've been working with the majority until you decided to fast track this piece of legislation. And I'm not quite certain why that would be. There's no need to fast track this particular piece of legislation. Democrats in the committee care about transparency, we care about efficiency, and we care about the effects of consolidation. These issues are important not to just our districts, but to everybody's district across the country. But the majority chose to forge ahead without that consensus. And the only thing that I see as maybe a possible reason is to provide some sort of protections to those private equity firms that we have heard about today, and that I know that folks on both sides of the aisle care about. Our colleagues on the Energy and Commerce Committee took this issue up. They didn't sidestep this. They didn't make it a partisan issue. They recognized that private equity involvement in healthcare is causing problems for our constituents. They took it on. They addressed it in their legislation. We could be doing the same thing here today. We're about to enter the August recess. This bill isn't coming to the floor for at least another 8 or 10 weeks. So I still fail to see the rush to get this thing out of committee without first reaching a good bipartisan work product. The bill could have been a lot better. It still can be a lot better. And I would urge my colleagues on the other side to try and pursue that. As I say, the recess is coming up. We could be working on this and have a good bill, one that would reach the president's desk, because this one's not going to, and would be signed into law and help the people that we all represent. So again, thank you, Mr. Chairman. I yield back.
I just want to point out, we've worked for several months on both sides trying to get to the best agreement that we possibly can. In fact, I've asked my team, we've put in more than 100 hours in trying to make this as bipartisan as possible. And the provisions that's within this bill, I haven't heard many people object to the provisions that's in it. I've heard objections to what's not in it. There's 10 different sections. 3 of the sections in general are bipartisan bills that are filed with members of this committee and also others. So, Mr. Winstrup, you're recognized.
Mr. Chairman, I move to strike the last word. I want to thank the chairman for convening this markup today. As a physician, I know firsthand how important it is to increase transparency so that patients have flexibility in how and when they choose their health care. Today's package includes important provisions that will empower patients to make informed health care decisions that put the patient in driver's seat of their own care. I'm going to tell you, I've been here 10 years. I've been working on these issues for 10 years, so I would hardly call this fast tracking. Today's bill is an important first step in finding the right balance to improve transparency for patients without creating overly burdensome reporting requirements for the providers who care for them. And I would say that as a body and as a government, we should be focusing more on enhancing care and less on over-administration of caregiving itself. And we have to be honest with ourselves someday and take a look at some of the things that we have done to drive physicians to do things like private equity. I never practiced in a private equity situation, but I will tell you, part of the reason you have doctors here in Congress today is because this government has taken the joy out of taking care of people. And that's a fact. So I just want to go to another topic, but hospitals and ambulatory surgical centers play an important role in providing care to patients. My bill, the Outpatient Surgery and Quality Access Act, includes important measures, reporting measure requirements for ASC that would improve patient access to these vital facilities and the services they provide. I was pleased to work with Representative Maliotakis on the Protecting Patients from Middleman Act, a bill that would prohibit prescription drug plans and PBMs in Medicare Part D or Medicare Advantage from charging patients more in cost sharing than the net price of a drug. I'm pleased to see the Improving Seniors Timely Access to Care Act included in today's package. I've had situations where we get delays in cares waiting on prior authorization or denials from prior authorization, and the person making the denial has no liability for the delay in care that they may be rendering a patient. Look, today we're putting patients over paperwork. This package is critical for patient-centered care, and I urge its swift passage out of committee and on the floor, and I yield back.
Mr. Pascrell is recognized to strike the last word.
Well, it's a wonderful day in the neighborhood again. Mr. Chairman, good morning. I move to strike the last word. It's interesting, we're discussing health transparency today. However, Sherlock Holmes could not find the primary culprit of rising health costs in the bill before us. One of the largest threats to rising costs in our healthcare system is the private equity industry. This is a $151 billion elephant in the room. There is a place for private equity in many areas and in many issues. But the facts and the data are very clear. One of the largest threats to rising costs. I'll stand on that until proven wrong. Thanks to the leadership of our ranking member, Mr. Neal, this committee took on private equity in 2020. We have short memories. The chairman, Mr. Smith, you voted for it. Many of us voted for it. It was a bipartisan piece of legislation that laid down very careful rules. Not that they've been implemented. Very careful rules about investment into healthcare. We just have to step back for a moment and look at nursing homes and the costs and how they've closed and who now owns them. And the bottom line is the bottom line, and they've done a terrible job in helping the healthcare system become better. The time has come to do it again. What we did in 2020. You got to stand up. Mr. Kelly, you voted for it too. You voted for it. It's a bipartisan thing. You talk about it all the time. Once in a while, we try it. There are mountains of evidence underscoring how private equity's grasp on our healthcare system has harmed working families. I know you care about that. Private equity has an absolute fixation on revenues over patients. Every report that I've seen shows that, indicates that. And did they do a horrible job during the pandemic? And you know it, and I know it. The consolidation over quality and certainly access. This fascination has resulted in fewer services and higher prices for our constituents and payers. My friends, you know, I say there's no Democratic or Republican way to clean our streets. There's no Democratic or Republican way to bring health care to the United States until we come together on this issue, because there's nothing more important than your shelter and your health. We cannot continue to allow the vicious monster to take over our entire healthcare system. That's where we're going. Look at the numbers. Maybe you perceive it differently. Let me know about it. The bill before us today has no mention of private equity. How is that possible? Now, you started off on a bipartisan way, which I cherish. And you all know that many of you participated. But zip, zero, nada about equity, private equity. I know my colleagues do not want to be complicit in private equity's quest to soak patients in Medicare for every penny. Any bill claiming to address transparency that takes zero action to expose private equity's growth in healthcare is not worth the paper it's printed on. We don't want to do this. You don't want to do this. And yet here we are today fighting each other. We should have a bipartisan bill right here because we've done it already. I yield back.
Mr. Schweikert is recognized to strike the last word.
Thank you, Mr. Chairman. I'm actually pleased to hear part of the discussion about private equity, but there's actually a genuine solution. Do I have any folks here who are in real estate or other types of investment? You know, we all grew up with an old saying. I'm not thrilled with the saying, but excess profits lead to ruinous competition. Basically meaning if I'm getting more than market rate of return in my investment, whether it be this or that, I get competition. Private equity's job is to try to find where there is a higher rate of return. Okay, in that case, it's our fault because we're not creating an environment where, hey, there's this rate of return, competition is going to come in and bring it back to the mean. We have created so many rules, so many mechanisms, so many restrictions. And that's why and Mr. Doggett, who I think has disappeared on me, he and I have been having for a couple of years, there you are, for what is competition in healthcare? And you know my fixation that this thing in some ways, the thing you can wear on your body, the fact that yesterday another company announced that there's a blood glucose band you just put around your wrist and it can manage your blood glucose and your macros and those things for helping pre-diabetic populations. And it turns out we need competition in the delivery of healthcare, but is it another clinic or is it, could be a clinic or could be the technology you wear in your body, and that competition is what bends that cost curve and takes away the desire for private equity saying to chase the excess profits. Oh, absolutely.
The major objective is not competition. The major objective is patient outcome. Can I finish?
Oh, sure.
And I've looked at the data, and I don't know what the heck data you're looking at. The data shows that under private equity, not all the time, I think there is a place for this, not all the time, but many times, the patient is secondary. And we saw that. I thought was a good example. I don't think it's hyperbole to talk about nursing homes when we're talking about health care and the health of health care.
Okay, but to my friend, Mr. Pascrell, in some ways we're saying the same thing, but then walking by each other. Choice, availability, whether it be the transparency of knowing here's my outcomes, here's my price, is how you take care of patients. If you have a single silo, if this is functioning my only choice, yes, it means they have no need to be price efficient, but also you and I, you have a medical issue, your optionality is, for me, I have hypertension. I want to manage it, but damn it, I want to manage it by wearing something on my wrist. Every morning I do my blood pressure. Please let me finish. It's not through more government command and control, it's actually for more competition, but competition, you need to open up our brains. Competition is technology. And I believe the chairman and I have had conversations of hopefully this fall and back to Mr. Doggert's and previous conversation, the discussion of what is healthcare? What does it mean when you have a society that apparently next year we'll have 12,000 of our brothers and sisters turn 65 a day? We need to actually rethink what does it mean to provide health care in a society where in the next couple of years of adults, 20% of our society will be 65 and up receiving Medicare. Medicare is almost all future debt. You know, we borrowed $63,000, we're borrowing $63,000 a second right now. And we're going to dink around, sorry for that word, on little tiny things. So price transparency is absolutely wonderful. But in a third-party payer system, it's not a motivator. We need to be much more cooperative and disruptive, and that disruption is what deals with your concern on private equity because they have to compete with other people. But it also may be the fact that our discussions on things like GLP-1s and other things, taking on obesity, taking on diabetes. Diabetes is 33% of all healthcare spending. Maybe part of this discussion is where does it take, if we had a society that was actually healthier, is the fastest way to crush the price of healthcare. And with that, I yield back.
Thank you. Mr. Davis is recognized to strike the last word.
Thank you, Mr. Chairman, and I move to strike the last word. When it comes to H.R. 4822, the Healthcare Price Transparency Act of 2023, much more needs to be done. Healthcare should never be a piece or half of a loaf, but a holistic approach to ensure comprehensive care is the main objective and goal for all beneficiaries. Once knowing the price of a plan, procedure becomes important. It is important for a patient to have a balanced approach to include all sectors in the healthcare system to meet the need for the highest standards possible and to be fair and just without exception to other healthcare sectors. We need more and not less transparency in key health sectors to provide consumers the ability to make optimal decisions with respect to their health plan and care. For instance, we need to require Medicare Advantage plans to report on the standard uses and numbers of prior authorizations. Not having national standards for prior authorizations can lead to unexplained or unjustified variances in benefits. In addition, another critical aspect is to know the professional qualifications and monitoring of performance of those individuals performing prior authorizations. Too many denials could be a red flag for financial conflict of interest, a lack of knowledge of the individuals performing the review. Excessive denials jeopardize the health of the beneficiary and essentially denies the beneficiary a contracted benefit correctly. The problem is much broader than just Medicare Advantage plans. All systems that utilize prior authorization should have stated deadlines for decisions, review of performance of their employees, and none should have a system that denies appeals. Many private insurances authorization systems do not allow appeals, which can be potentially harmful or potentially fatal for the patient. Another negative aspect of H.R. 4822 with respect to private equity firms buying hospitals and private practices. Hospitals and provider facilities should be congruent with the priorities of community needs to deliver high-quality, equitable, and timely care. This is not necessarily consistent when it comes to profit-centered entities' goal to maximize stakeholder profits, returns compared to high-quality care for patients. Some analysts have reported that private equity is the cause of adverse health outcomes. More transparency is needed rather than less. I thank you, Mr. Chairman, and yield back.
Mr. Arrington's recognized to strike the last word.
Thank you, Mr. Chairman. We all agree that in some cases and in some classes of drugs, the markets are working. In generics, biosimilars, and other aspects, it's working to drive costs down. But in some cases and in some classes of drugs, it's not working, and it's not working too often. Between July 2021 and July 22, over 1,200 drugs outpaced inflation. The average price of those drugs were 31% in terms of the increase of those drugs. Some drugs in that group increased by 500% or $20,000. I've said this before, and I believe that in this principle, markets are the best way to deliver value. Markets are the best way to get at that equilibrium of cost and quality. Two fundamental operating functions of markets are competition and consumer choice. Competition drives cost down and quality up, and you can't have consumer choice if you don't have meaningful information to empower consumers to shop for the best value for the needs of the consumer and their families. Drivers of this inordinate pricing in drugs is A, lack of competition, and B, lack of transparency or meaningful information for consumers. On the competition side, it's consolidation of power within a few in the supply chain and vertical integration along the supply chain. And I know, Mr. Chairman, we will get at that at some point, but I think that's a fundamental problem that has to be addressed. I know you do as well. I think another distortive dynamic that is causing the increase in drug prices is the manipulation of intellectual property by drug manufacturers to extend their exclusivity, or, as we say in West Texas, monopoly forces, right? There's utility in IP. That's a constitutional sort of protection of private property, and it encourages innovation and cures, but you game it and you can gouge patients and consumers and you can distort the market. That's what's happening, and I look forward to addressing that. But today, I'm proud to introduce a bill that would address the lack of transparency in the real price of drugs because of this interesting relationship between insurance companies and their negotiators, PBMs, and drug manufacturers. And I've long held the view that it's one thing to negotiate the price and include your profit and to negotiate and compete for that, but then to include a rebate, or what we call in West Texas a kickback, that we know nothing about. That is, and by the way, the reason they're able to do that is because of an anti-kickback waiver. Like who signed off on that deal? Mr. Chairman, I'd like to do away with the anti-kickback waiver altogether, or I'd like to push the rebate to the point of sale, and I've introduced legislation to that effect. But at a minimum, and a good place to start is, let's shine a light on that opaque exchange where there's not only profit, but there's this kickback that presumably, and is advertised, at reducing the premiums for consumers. So it's in our best interest to not know about that, apparently.
One aspect to this is that PBMs negotiate also on behalf of employers. And this bill will require that PBMs reveal their net prices, that is, their negotiated price, net the rebate, so that employers negotiating on behalf of their employees can have the information to be true consumers and shoppers and exercise their right to get the options best suited for their employees. Seems like a good thing. That's just one dial to make the markets work better. And this bill will address that by making that net price, the real price of drugs, available to employers. And I thank you for the indulgence, and I yield back.
Thank you. Ms. Del Bene is recognized to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word. Over 30 million seniors are currently enrolled in a Medicare Advantage plan, and that's over half of the Medicare eligible population, and it continues to rise year over year. And while there are many reasons seniors choose these privately administered plans, the widespread use of prior authorization delays and discourages much needed care that many enrollees are entitled to. This means that seniors, their families, and their providers are making multiple phone calls and faxing documents to insurance companies. Providers spend an average of 13 hours a week on prior authorization paperwork, often for procedures that are ultimately approved over 95% of the time. That's why I led the effort in the House alongside Congressman Kelly, Bera, and Bouchon to modernize and streamline this very outdated practice. The Improving Seniors Timely Access to Care Act would help Medicare Advantage enrollees get the care they're entitled to faster. This bill passed through the committee and then through the House unanimously last year. And we've always moved in a lockstep bipartisan way to develop and advance this legislation along with our partners in the Senate. In June, we led a letter signed by over half of Congress, both in the House and a filibuster-proof margin in the Senate, calling on CMS to finalize their proposed prior authorization rules and strengthen them to speed up the prior authorization process. But rulemaking is not a replacement for legislating. There's a clear path forward here in this Congress to build on our bipartisan momentum and get this bill over the finish line. But what hurts our chances is when we play politics with bipartisan common sense proposals. That's why I'm disappointed that these important bipartisan reforms were sandwiched into a Republican written package today that includes many unrelated health policies that we on the Democratic side have concerns around. We could have reached a bipartisan deal to increase transparency and lower health care prices, but unfortunately, Republicans chose to walk away from the negotiating table and move forward alone. I'm particularly dismayed that the Republican proposal exempts Medicare Advantage plans from important transparency rules that are required for employer and individual health plans, in many cases offered by the same insurance company. These rules allow patients to know how much they'll have to pay at a provider for a specific procedure. Why should people have access to this important information when they're 64 or younger, but not when they turn 65? It just doesn't make sense. Republicans in this package also propose funding cuts for our nation's cancer hospitals. These cuts and the precedent they set would restrict access to cancer treatment for thousands of patients in my home state and millions of patients around the country. At the end of the day, we only help people when we have legislation that passes the House and the Senate and reaches the president's desk. In divided government, we need bipartisan solutions. I hope we can find a truly bipartisan path forward that includes the Improving Seniors Timely Access to Care Act so we can modernize this outdated practice and deliver better care for our seniors. Thank you, and I yield back.
Mr. Ferguson is recognized to strike the last word.
Thank you, Mr. Chairman. As we sit here today, and as we've talked about many times in this room, we look at where we are in healthcare today in its entirety. And we ask simple questions about America's health today versus a decade ago. Are Americans paying more for health care today than they were a decade ago? The answer is yes, by an exponential amount. Are Americans healthier today than they were a decade ago? And the answer is no, by every metrics. And are American families' pocketbooks and their livelihoods being affected because they can't afford to pay for their health care bills? And the answer is yes. And that is all the result of a healthcare system that is driving towards vertical integration, that is not transparent, that is full of incestuous relationships, and a lot of things that just simply are not clear to both Congress and most importantly, to the American people. The only way to get at that is transparency. To my friend from New Jersey, whose comments on private equity. Private equity and capital is going to go where the greatest profits are. And because we have a system that guarantees that more and more money is being funneled into the healthcare system, it's natural that without competition, those are where the greatest profits are going to be. And so as we go through this process, I would just say we need to recognize that this body created the system that is in place right now. It is a system that is driving up patient cost and driving down health outcomes. There's not one metrics that shows that people can afford health care today better than they could a decade ago, and there's not one metrics that shows that Americans are healthier today than they were a decade ago. We have got to go with this, and getting at the transparency piece of this is an important first step. So, Mr. Chairman, thank you for bringing this piece of legislation forward. We can continue to push ahead on this issue, but transparency and getting at transparency is a key part of correcting the problems that exist in our healthcare delivery system today. With that, I yield back.
Ms. Chu is recognized to strike the last word.
I move to strike the last word. Mr. Chair, I'm concerned that both of the bills considered in today's markup leave out a key component of the health care price transparency discussion, the consumer. Neither of these bills include provisions to help consumers navigate the copious amounts of data provided by hospitals, insurers, and other healthcare providers. What should someone do if their insurance doesn't cover the service they're shopping for? What steps can a patient take when they receive a medical debt notice or a prior authorization denial? How can we make sure people know how to enroll and disenroll from their insurance or from Medicare? Or better yet, how can we make it easier for the millions of Americans currently losing their Medicaid to navigate the steps needed for them to re-enroll in health coverage? Unfortunately, today's bills do nothing to help consumers answer the questions like these or educate consumers on how to use price transparency data to make informed healthcare decisions. Price transparency is not a useful tool for patients to determine the value of shoppable services unless it's paired with corresponding and useful information and resources. What's more, the bills considered today fail to require transparency amongst one of the most rapidly growing opaque actors taking over our healthcare system, private equity. Studies have repeatedly shown that profit motives in private equity transactions drive up consolidation and healthcare costs, harm patient care, and even lead to increased death. If we're serious about improving transparency in healthcare, we must require transparency in the private equity space while ensuring that health systems put patients first and cannot be gamed by investors trying to make a fast profit on the backs of consumers and taxpayers. I urge my colleagues to work on proposals that require transparency across the entire continuum of healthcare, as well as measures that will actually help consumers utilize and understand the data being provided to them so that they can better access quality, affordable healthcare services. I urge opposition to the two bills under consideration today, and I yield back.
Estes is recognized to strike the last word.
Well, thank you, Mr. Chairman. And I also want to thank my colleagues for bringing this important topic about transparency and in particular the issue of prior authorization. I particularly want to thank my colleagues, Mr. Kelly and Ms. Delbene, for their persistent leadership on this important issue. It's exciting to see some movement now recently, United Health changing its policies
to minimize use of prior authorization. It's important that we don't let up now, which is why I'm glad to see language from their Improving Seniors Timely Access to Care Act included in this markup. If used properly, prior authorization can be a useful tool to help manage the cost of health care, a good thing we'd all like to see. Unfortunately, that's not what's happening now. Prior authorization process is broken, leading to adverse outcomes for patients. In a recent American Medical Association survey, 1 in 3 doctors reported that prior authorization delays have led to serious adverse health events for their patients, such as hospitalizations or even death. This is outrageous. Doctors should be free to give their patients the care they need when they need it. And prior authorizations aren't even functioning as the check they're intended to, since 90 to 100% of the requests get approved in the end. This broken process takes a toll on patients, their families, caregivers, doctors, and even the exact financial toll on health insurance providers and ultimately the American consumers. You know, I witnessed this firsthand within the last year when a family member had a health issue and had to spend extra time in the hospital waiting on prior authorization just to go into rehab. And it's one of these issues that we need to address. It'll ultimately save money. It'll ultimately make sure that the outcomes for patients is better than what they would have received without this. Thankfully, the legislation we're considering today offers solutions and process improvements that will make a difference in the health and the lives of the individuals we represent. It's important that we get this right, since more than 28 million people are enrolled in a Medicare Advantage plan, roughly half of the eligible Medicare population. The changes proposed in this legislation will put physicians in the driver's seat so that they can deliver timely care to their patients and minimize unnecessary wait times for patients. Cutting time dealing with bureaucratic red tape means more time taking care of patients. I'm glad we're finally bringing this process into the modern era by also establishing an electronic prior authorizations process. This will help streamline the process and make it possible to provide physicians and patients decisions in real time. I hope my colleagues join me in supporting this critical legislation that has the potential to dramatically improve and even save lives. And with that, I yield back, Mr. Chairman.
Mr. Evans is recognized to strike the last word.
Thank you, Mr. Chairman. I move to strike the last word. Democrats are serious about transparency in health care to help ensure people know and understand how much they are paying and what they are getting. Unfortunately, today's Swiss cheese approach is not what Americans need. The ranking member negotiated in good faith, but unfortunately, the majority only wants transparency for some. The failure to include Medicare Advantage and private equity fails the American people. The people of Philadelphia know too much what happens when private equity takes over health care. In 2019, Hahnemann Hospital, which was owned by a private equity company, closed its doors and severely limited access to health care for my constituents. At the time, I pledged no more Hahnemanns. As the ranking member knows, I've worked to keep that pledge. Increasing transparency is a part of that. If the state and the federal regulators had a better window into what was happening when these firms was taking over healthcare providers, tragedies such as the closure of our hospital might not have been presented. I hope in the future we can work to address this problem and increase transparency for all Americans. I thank the chairman, and I yield back the balance of my time.
Mr. Smucker is recognized to strike the last word.
Thank you, Mr. Chairman. This has been a really fascinating discussion about health care in our country, discussion around private equity. Just the way I think about this and the way I think about health care, I think our health care in the coming decades, 20, 30 years from now, will look far different than what we have today. We are on the cusp of major breakthroughs that will change how we think about aging, how we're able to identify disease, and how we treat those diseases. That will have a dramatic impact on the lives of every American. Those changes, those potential changes, will not be driven by the government. Those changes will not be driven by government regulation, other than some research that we help through NIH provide some research and so on. But by and large, these changes are driven by companies and individuals who see opportunities to do things in an entirely different way. I'm talking genetics, I'm talking a lot of different treatments. And I think the obsession on the profit factor and on private equity really misses the point. We really want to have a system that incentivizes individuals to take that risk and be able to reap the reward. Imagine this little device. Mr. Schweiker lifted his iPhone. Imagine if we had tried to regulate how our mobile phones would have been developed at the government level. Imagine if we had restricted companies with a profit motive from providing that service. And imagine how much that's changed our life. We're going to see that kind of breakthrough in healthcare over the next few decades if we allow that to develop. On the bill that we have today, this is just a small change, and I think all of us want to ensure that Americans can lead healthier lives, they can age longer, and that they can have access to the care they need, they can have access to the insurance they need at a price that they can afford. So there's a lot of discussion that we should be having around health care. The bills today are just two small pieces that, by the way, don't even mention, to my knowledge, private equity. This is about increased transparency. It's just, again, one small piece, but these are great provisions that are included in these bills that would increase transparency for patients, which is a key component in helping them to make decisions for themselves that will reduce healthcare costs. We all know how much premiums and deductibles are rising, much more than wage growth. So this is one of the areas where I hear from constituents, I'm sure all of us do, about the impact, particularly in today's with the inflation that we're seeing today. Healthcare costs are having a dramatic impact on families all across my district. So I'm glad we're moving these bills. These are bills that will advance patient-centric reforms that are going to help all Americans, and this should be bipartisan. Yes, there are provisions that are not included that I'm hearing a lot about from the other side, but we should all be able to support the provisions that are in these bills that will help my constituents and help your constituents. So again, I'm proud to support these bills. I thank the chair for moving these bills, and with that, I yield back.
Ms. Miller is recognized to strike the last word.
Thank you, Mr. Chairman. And I do move to strike the last word. I've said this before in previous price transparency hearings, and I'll say it again. The health care system is the only one that consumers don't know what the price is of the service before they receive it. And I think we owe it to the patients to change that. Patients should be able to know up front what a service is going to cost them before they make the decision to receive it. My bill, the Clinical Laboratory Price Transparency Act, does just that. The legislation requires clinical labs under Medicare to publish their cash prices so that patients that need basic medical procedures like a blood draw or a test know what the bill will be before they get the procedure. I am happy that this common sense policy has made it into our larger price transparency package. Coupled with the other important transparency reforms in the larger bill, this committee is taking an important first step to empower patients with the information that they need when they are seeking care. I look forward to passing my bill and this package out of the committee. Thank you, and I yield back.
Mr. Doggett is recognized to strike the last word. Mr. Doggett is recognized to strike the last word.
Thank you very much, Mr. Chairman. The Healthcare Price Transparency Act, as I've said in my opening statement, those of us who believe in transparency, in the bill that you have presented this morning, we have no choice but to vote against this bill because it does not match its title. It does not match its title, and I have listened to your comments, Mr. Chairman, and that of our Republican colleagues to see if a single one of you could explain why it is that you have provided less transparency than a bill approved by the Commerce Committee on a unanimous basis, all Democrats, all Republicans. Now, I frequently disagree with the Commerce Committee on its work product, and in fact, I think we could strengthen and improve and broaden the transparency beyond what the Commerce Committee has done. But if transparency is such great value as each of you have heralded this morning, why is it being denied by you deliberately to 32 million Americans in the Medicare Advantage system? And I would be glad to yield some of my time to you, Mr. Chairman, if you can give us any justification for your exclusion and weakening of this bill from what Commerce proposed as to why you have excluded 32 million Americans from its benefits.
Mr. Doggett, I would have to disagree with your statement. I believe we've actually strengthened and made this a better bill. And I truly believe that the Ways and Means Committee wants to write their own health care policy and not allow Energy and
Maybe
Commerce
it's
to write
that.
it.
And thank you, Mr. Chairman, because that is not a justification or an explanation as to why Medicare Advantage has been excluded from this bill. There's no additional protection for those 32 million people. They get nothing out of this bill. And the same thing is true with reference to private equity. I agree with the colleagues that we just heard from our Republican colleague about the role, a positive role that private equity can sometimes play. We are not denying private equity in this. We're just asking for disclosure. And that's all the Commerce Committee asked for, is disclosure so that we get an idea of how broad the impact is. It's been very harmful, as my colleague Mr. Evans pointed out, in Philadelphia in hospitals. It's been very harmful over the country in nursing homes and the way they have been affected. But there may be some positive benefits, but let's just get the facts out there. And again, Mr. Chairman, is there any justification or reason why you refuse to have disclosure and transparency concerning private equity as the Commerce Committee approved it on a unanimous bipartisan basis?
We are all in support of transparency. We need to get to the right language in any aspect. There's several bills that we've been working towards.
Thank you, Mr. Chairman. So I'll take that as a strong no, that there is no justification for excluding private equity. And then your claim is that, you know, all these Democrats, they just complain about what's not in the bill, not what is in the bill. Well, I have a complaint about what's in the bill, and it was demonstrated in the discussion about pharmaceuticals. This bill is not ready for prime time. The consumer who goes in the middle of the year to get a prescription may end up actually being overcharged for it and never getting a dime back. There is a reason why the Center for Medicare Services, Medicaid Services, has not blessed this proposal, because it's not ready to go. It's not a bill that can be implemented in its current form. It is deficient and defective in that regard. Mr. Chairman, I believe in the power of transparency. I think Mr. Arrington stated it well, that these markets to work, you have to have good data and information, and you have to have competition. The problem with pharmaceuticals is we have neither, and this bill will not advance either. There is no responsibility placed on a pharmaceutical manufacturer in any meaningful way by this bill. Those Americans who cannot afford their prescriptions today will not be able to afford them tomorrow if this bill is adopted. Data alone will not lower prices. It can empower people to lower prices, but it won't do any good for those people with Medicare Advantage. The issue of prior authorization. Yes, we acted and approved on the floor of the House prior authorization last year, and when it was not finally adopted in the Senate, the administration moved swiftly. It issued a rule in December. It took public comment, and it's about to finalize that rule. And the chairman and the members of the committee have yet to indicate a single thing about the administration's rule on prior authorization that needs to be changed. I think there are a few changes and improvements that will be made as a result of the public comments, but to say you're going to hold the administration accountable, really all you're doing is affirming what the administration is already doing to resolve this problem, not provide any additional protection to American healthcare consumers. I yield back.
Mr. Murphy is recognized to strike the last word.
Thank you, Mr. Chairman. I think this has been an excellent and robust conversation this morning. I think a lot of good points on both sides of the aisle have been said this morning. I appreciate you and your team bringing the bill to the floor. I think this is an excellent first step. Again, a first step in trying to bring transparency to government and rather to healthcare. I will submit this. With so much more work to go, I think the transparency of trying to get prices out, to be very honest with you, really does very little to move the needle. So why don't we back up a little bit, and I'll agree with some of my Democratic colleagues and disagree with them on other points on what true transparency means. If you look at the cost of health care, and if we will examine the cost of premiums since the Affordable Care Act came in, they have gone up over 140% in that period of time. And so let us ask really where the transparency is, If you look at what has happened to health care, why are doctors leaving healthcare? Why are they joining private equity firms? Why is now the largest single insurer in this country control 15% of the U.S. insurance market, 28% Medicare Advantage? Their PBM, again, vertical integration, controls 20% of total adjusted claims. They're affiliated with offshore rebate aggregators. Their specialty pharmacy is the third largest in revenue. They're the largest employer of physicians in the country, and now they have a payday loan service to target physicians will they pay. Why is all this happening? And I'll say United Healthcare, if you look at what their stock prices have done in the last 5 to 8 years, the company to which I was referring, so many others, this administration is protecting the middlemen. They are protecting the middlemen, such to the point, in fact, where doctors, those of my partners, cannot afford to pay their employees. CMS now wants to come up with another glorious cut to doctors, another one. What other field expects to be cut? So when you're cut and cut and cut, what do you have to do? You either give up, you become a concierge service, you sell out to private equity, or you become part of a massive Borg of hospital administrations and places like United Healthcare, these massive vertical integrations that have absolutely destroyed medicine. We like to beat on pharmaceutical companies, and yes, I've met with them and I've tried to help them on some of the things that they can help improve their images. But guys, look, the middlemen in America, the insurance companies, the PBMs, the private equity firms, the payment aggregators, all of those things are what are truly destroying medicine in this country. No longer is it about a doctor and a patient. It's about a doctor and the 15 other people in the middle between when the doctor and the patient and how they get paid. So if we want to really talk about transparency, yes, this bill is an excellent step forward in the first step, but until we bring those individuals before this committee and how they explain how they are essentially extorting the American patient and bleeding them dry, being the number one cause of bankruptcy is healthcare, to our true causes to it, we're not going to get to the answer. And by the way, the administration, with the No Surprises Act, a good bipartisan bill came out of this committee, a good bipartisan went over to the chamber. President Trump signed it, and what has happened with CMS? They absolutely disregarded the intent of the law and gave every power to the insurance company, now to the point that the fact that physician companies are going out of business because they haven't been paid. So, no, I'm sorry, guys. The real middlemen, and that includes CMS, the absolute explosion of the burgeoning bureaucracy of CMS, the more payments, the more regulation. This is what we really need to work on in transparency. This bill is an excellent step. No, it doesn't have everything in it. No, it doesn't. But this is an excellent step, and if we're actually really wanting to deal with the cost of health care in this country, it's not cutting doctors' salaries. It's going after the true middlemen in the country where nowhere else in this world has this issue. Thank you, Mr. Chairman. I'll yield back.
Mr. Fitzpatrick is recognized to strike the last word.
Thank you, Mr. Chairman. Mr. Chairman, I speak today on my bill titled the Health Insurance Price Transparency Act of 2023, which is Section 102 of this piece of legislation. Mr. Chairman, my bipartisan bill provides key patient protections by promoting transparency and will help consumers better use health insurance pricing information to shop around for the best option for both patients and their families. This piece of legislation codifies an existing rule that health insurers are already complying with, while also strengthening transparency and reducing duplication. Moreover, this bill will provide patients with the ability to learn and understand how much a health service will cost them through a price transparency tool. And in addition, it makes machine-readable files public on prices of healthcare services, which will also help lower costs for patients. Mr. Chairman, all Americans deserve to know the cost of their healthcare services, and this bill helps to achieve exactly that. I was proud to introduce this bill. It is bipartisan. It's been included in today's markup, and I encourage my colleagues to support it. I yield back.
Mr. Higgins is recognized to strike the last word.
Thank you, Mr. Chairman. According to the Kaiser Family Foundation Sick Profits investigating private equity's takeover of the healthcare system in America, private equity in 2021 spent $206 billion into more than 1,400 healthcare acquisitions. Private equity has spent nearly $1 trillion into nearly 8,000 healthcare takeovers in the past decade. Private equity playbook is ill-suited for healthcare. Private equity buys healthcare practices, hospitals, incrementally under $100 million each acquisition to do what? To avoid federal antitrust scrutiny, because that scrutiny would result in a very poor picture of private equity's influence as it relates to the American healthcare system. Private equity is not healthcare professionals, they're moneymakers exclusively. They use their leverage not to enhance services, but to cut services. The United States healthcare system spends $4.5 trillion, or $13,000 per person this year. It's 18% of the U.S. economy. Life and these kinds of aspects of it, as it relates to healthcare, is all about leverage. Private equity hurts patients. It hurts physician groups. It hurts hospitals. It hurts the American people. We should be using our leverage in the United States government as a purchaser of healthcare. The federal government spends $1.7 trillion every single year in Medicare, Medicaid, Veterans Administration, and tax treatment. It's 38% of the total. The best way to provide patient protections is for this body to, in a bipartisan way, establish very clearly, unequivocally, that we are seeking, first and foremost, to protect patients and to enhance the ability of physicians to help those patients. When you look back at the Affordable Care Act, before the Affordable Care Act was enacted, an insurance company could deny you coverage because you had a kid who was stuck with childhood cancer. You can't do that anymore. It's against the law. 10 essential services, no co-pays for preventive services. All of those speak to a healthcare system that's seeking to improve, to put the decision-making healthcare choices between a physician and the patient. That's what we should be talking about here today. Private equity is ruining healthcare in every community across this nation. And I yield back.
Ms. Still is recognized to strike the last word.
I strike the last word. Thank you, Mr. Chairman. I applaud the committee's work to make price transparency data more accessible for patients and employers. This is a perfect opportunity for real change. Rising healthcare prices are hurting my constituents and employers and all of their employees. The only way to make healthcare more affordable is to understand the root causes of healthcare spending. Today, families are left in the dark about the actual cost of procedures and services. The this lack of transparency prevents patients from making informed decisions. For example, a C-section delivery in my congressional district can cost between $8,598 to $23,648, about $15,000 differences between lowest to highest price. And a CT scan can range from $134 to $4,065 at the same hospital. It should be common sense for patients to know the upfront costs for care. Unfortunately, only 1 in 4 hospitals are estimated to be following hospital price transparency rules, yet only 7 hospitals out of 6,000 nationwide have ever been fined for non-compliance. And when hospitals do report their price data, they often come in confusing formats and file types that make it difficult for anyone to read or download. This was all raised by our witnesses in our full committee hearing on healthcare price transparency, and we are now following up on our promises to empower patients by unleashing price transparency. This is why I recently introduced the Hospital and Ambulatory Surgical Center Price Transparency Act. This legislation requires hospitals and ambulatory surgical centers to publish their prices, requires publication with respect to non-compliance, including publishing information regarding non-compliance on Hospital Compare, and provides civil monetary penalties for non-compliance, while also allowing the Secretary to waive or reduce the CMP if it would harm any access to care. I am proud to see this effort get included in the Healthcare Price Transparency Act, and I urge my colleagues on both sides of the aisle to support this patient-driven initiative. This will help not just my constituents, but other districts' constituents too. And thank you so much. I yield back the balance of my time.
Ms. Maliotakis is recognized to strike the last word.
Thank you, Mr. Chairman, and thank you to the committee staff and my colleagues who worked tirelessly to put this legislation together. This is important legislation. It addresses a number of issues that we've been speaking about in this committee: rapid consolidation in our healthcare system, competition among healthcare providers, and improving price transparency for patients so that they can access clear and comprehensive information to compare costs, evaluate options, and ultimately make informed decisions about their health and financial well-being. I appreciate the committee working with me to recognize providers that experience greater challenges, like those in health professional shortage areas, and allowing them more time to financially prepare for changes to their reimbursement rates for drugs administered in Medicare Part B. I certainly support policies that ensure Medicare patients benefit regardless of the providers that they see. And in many cases, this will lower copay for our constituents. I also believe it is important to reinvest some of the savings that result from the policies being considered here today in a targeted way that shore up hospitals facing financial challenges and those that care for a substantial number of low-income patients. I'm also very pleased to see legislation that I introduced with Congressman Brad Wenstrup, Protecting Patients from Middlemen Act, included in this package. Our legislation would prohibit prescription drug plans and PBMs and Medicare Part D or Medicare Advantage from charging patients more in drug cost sharing than the net price of a drug. This is a common sense patient protection that will ensure that PBMs are not forcing patients to pay more for their medicine than what they negotiated in their coverage. As we continue to address vertical consolidation in the PBM space, I also want to encourage my colleagues to support legislation my colleague Buddy Carter and I introduced Protecting Patients Against the PBM Abuses Act. Our proposal will help to correct these perverse issues and bring relief to patients by ensuring PBMs are not compensated for putting the highest priced drugs on formulary. 3 PBMs control 80% of all prescriptions managed in the U.S. They own and are owned by insurers and have vertically consolidated to own everything, including doctors, pharmacies, and rebate aggregators. Congress must also end this conflict of interest. If you are a PBM, then you be a PBM. But PBM should not be allowed to be the insurance company and the pharmacy too, because they're profiting by dictating to their small mom and pop competitors how much they can be reimbursed for dispensing medication, and they also profit by making sure that patients pay more. I look forward to working with the committee on legislation focused on the anti-competitive practices of these middlemen and breaking the link between drug list prices, rebates, and PBM compensation. Thank you, and I yield back.
Ms. Tinney is recognized to strike the last word.
Thank you, Mr. Chairman and Ranking Member Neal, for holding the markup on the Healthcare Transparency Act. Just for the record, 30% of all hospitals are owned by private equity, so less than a third. Just wanted to clarify that fact for our listening audience here. In this committee over the past 6 months, we've heard from countless Americans with 2 major complaints. Healthcare costs are out of control, and it is far too difficult to know the cost of healthcare services before you receive them. This can be made even worse through a practice called dishonest billing, where outpatient and physician services are billed at the higher hospital rate. The price shock can be startling. Back in 2021, NPR reported on one woman who was charged 10 times the usual amount during her annual arthritis treatment visit. With hospital prices now accounting for 1 out of every $3 spent on healthcare in this country, incidents like this can be a major driver of cost. MedPAC has estimated that the dishonest billing cost Medicare $1.6 billion in 2015, ripping off both our seniors and taxpayers. Thankfully, this legislation today contains portions of Congressman Hearn's Bipartisan FAIR Act, of which I'm a co-sponsor, to finally tackle this practice. The bill will require every office with a large hospital system to obtain their own national provider identifier number so payers can differentiate between a hospital and a non-hospital setting. It is a common sense way to reduce healthcare costs and fraud without placing an additional administrative burden on the hospitals. Instead of billing a procedure under the hospital's network identifier number, the doctor's office will simply bill the procedure under their own identifier. On top of this important change, the bill will provide thoughtful improvements to healthcare price transparency that both decrease the administrative burden for providers while ensuring we improve patients' access to essential information. This legislation will also limit out-of-pocket drug costs for patients, ensuring seniors under Medicare Part D are never forced to pay more than their plan's negotiated net price. Finally, the bill will take a real first step toward addressing vertical integration in the healthcare industry, requiring a MedPAC report on the integration of Medicare Advantage organizations, healthcare providers, pharmacy benefit managers, and pharmacies generally. Over the years, we have seen how consolidation in the healthcare sector has often raised costs while decreasing the quality of care. Gaining a greater view of these trends will help guide us to create new policies to strengthen our healthcare marketplace. I'd just like to thank the committee for their hard work on the bill over the past several months. The majority staff has spent countless hours meeting with healthcare experts, minority staff, and members to craft this legislation. It is yet another example of how our legislative process this Congress can deliver to the American people, not to mention all the people that have come to see numerous members on this committee to discuss real solutions. And I think this step brings us one closer to having solutions to providing better health care and more affordable health care, and obviously transparency. And I thank again the chairman for bringing this forward, and I urge all my colleagues to support this piece of legislation. And with that, Mr. Chairman, I yield back.
Mr. Carey is recognized to strike the last word.
Thank you, Mr. Chairman. Mr. Chairman, I move to strike the last word. Today's package is an important first step towards healthcare price transparency and includes many wins for patients. I look forward to working with my colleagues on this committee to ensure that the requirements in Medicare Part B provisions do not have unintended consequences on healthcare providers in my home state of Ohio. It is important that we strike the right balance of protecting patients without putting burdens on those who provide their care. Thank you, Mr. Chairman, for giving us this opportunity to discuss policies to improve the lives of Americans, and I look forward to continuing to work on policies to make health care more affordable for Americans, and I urge swift passage of this bill. I yield back.
Seeing that there's no others to strike the last word, are there any amendments to the amendment in the nature of a substitute?
Mr. Chairman, I have an amendment at the desk.
Mr. Chairman, I reserve a point of order.
Mr. Buchanan has reserved a point of order. A point of order has been reserved. The clerk will distribute the amendment, and I ask the gentleman to suspend while the clerk distributes.
Thank you.
Mr. Doggett is recognized for 5 minutes.
Thank you very much, Mr. Chairman. This amendment is designed solely to address the glaring omission by the chairman of any of the benefits of transparency for 32 million Americans who are in Medicare Advantage. This very week, we are celebrating the 58th anniversary of the affordable, quality health care that millions of Americans, that generations of Americans have enjoyed as a result of Medicare. But for so many, slick advertising or an employer that forces them into a Medicare Advantage plan has pulled so many Americans into these private Medicare Advantage plans, which too often end up being a disadvantage when they need the care the most. I've seen these recent ads that even suggest that if you call, you can get free groceries and free rent, or help with your rent, but nothing about limitations and restrictions that may even deny you access to your longtime family physician. Billed as a way of getting people to be healthier and save money, Medicare Advantage has become a cash cow. Taxpayers spend an average of over $1,500 per beneficiary for every one of those Medicare Advantage members. The Independent Medicare Payment Advisory Commission, or MedPAC, has conservatively estimated that we're spending $27 billion in overpayment to Medicare Advantage this year alone. That's money that could be used to either improve Medicare generally, like with hearing, dental, and vision, or to extend the solvency of the Medicare Trust Fund, which is equally important. Other independent experts have estimated that actually the amount that taxpayers are seeing wasted with Medicare Advantage is more like $75 billion. An oversight in this bill intended to provide better oversight is doing anything about the abuse. While the legislation offers some very modest improvements to data reporting by private Medicare Advantage and Part D insurance plans, it falls far short of what the Energy and Commerce Committee has advanced on a unanimous bipartisan basis. Neither committee applies the consumer protections required of group health plans to Medicare Advantage and Part D. This bill requires group plans to provide price information and a calculator for any cost sharing by consumers, what they'll owe for Medicare, for their medical care, but does not require the service for Medicare Advantage and Part D enrollees. My amendment extends these transparency protections to all. No reason, no justification has been provided to this committee as to why we will deny that assistance, that insight, that transparency to those 32 million Americans. It just shows the brute power of the health insurance lobby to get Medicare Advantage special advantage. This legislation strips the important protections that were there in the Energy and Commerce bill concerning what's called encounter data. Encounter data represents the detailed records of the care, treatment, and diagnosis for Medicare Advantage enrollees. To provide better oversight, these records should also include the amount of payment for health services, the amount of patient cost sharing, and whether the service or diagnosis was ordered through an at-home risk assessment. Such assessments are often the source of egregious overbilling, again, waste of taxpayer dollars. A recent OIG study found these assessments resulted in $2.6 billion in overpayments in a single year for diagnoses that were unrelated to any clinical care. My amendment would not only require more information on health risk assessments, the data must also specify where and when that assessment was made and by whom. This legislation also fails to address gaps in protections passed on a bipartisan basis in the No Surprises Act. The bill the amendment I advance would extend to the claims of these brokers and agents who claim they're offering independent, objective advice, but don't disclose how much they're paid and by whom to offer that advice. Despite such frequent talk of waste, fraud, and abuse by our Republican colleagues, when they have an opportunity to do something about it, whether it's here on Medicare fraud, they avoid taking the stance that will actually eliminate some of that waste. My amendment offers an opportunity to correct this position, and I hope it will receive support. I yield back.
Mr. Smith is recognized to speak on the amendment.
Thank you, Mr. Chairman. I certainly appreciate my colleague's intent, but I am opposed to adopting this amendment. The legislative language actually is unfortunately not ready to move through the committee. We've been working actually for months on health insurer price transparency, and this text we only recently received as it relates to what is described as Medicare Advantage transparency. While Medicare Advantage is a private insurance option for seniors, the market is fundamentally different than the commercial market, and we need more time to make sure we aren't creating any unintended consequences with this policy. 31 million seniors choose Medicare Advantage every year. Emphasis on choosing. This is a benefit seniors across the country, as well as my district, value due to the supplemental benefits and care coordination. So we need to be thoughtful and mindful and thorough in creating policies surrounding the MA market. I'm glad we're here today talking about transparency. It's important for all Americans to have access to the information they need to best plan for their own health care needs. But unfortunately, I have to say this amendment is not ready for prime time. We need more feedback from stakeholders. The Ways and Means Committee has a long-standing tradition of working policies through a very thorough and tough process. I urge my colleagues to vote no so we can have more time to evaluate this policy, this approach, and I urge, again, my colleagues to vote no. I yield back.
Mr. Pascrell is recognized to speak on the amendment.
Thank you, Mr. Chairman. Unfortunately, Mr. Chairman, this particular legislation, which caused the amendment, it's before us right now, provides a gaping hole in transparency. I support Mr. Doggett's amendment because I think the general legislation fails to apply the same transparency provisions to insurance companies offering Medicare Advantage plans or agents and brokers when they sell Medicare products. We don't talk enough about that either. More than 30 million Medicare beneficiaries are currently enrolled in Medicare Advantage plans. Over the course of the next decade, taxpayers will spend nearly $9 trillion on Medicare coverage through these private insurance companies, plans. Americans with Medicare Advantage deserve transparency too. Consumers with private health insurance will have access to price transparency, the tools that go with it, and price disclosures. But this bill does not extend the same shopping tools for Medicare Advantage. Under this paradigm, At age 64, patients will have access to information about the cost of services and how United pays its providers, but not at the age of 65. Why is that? That just doesn't make any sense. It's baffling why we would exempt plans that receive trillions in taxpayer dollars, trillions in taxpayer dollars, covering more than 30 million Americans from these supposedly common sense provisions. If they're so common sense, shouldn't they apply to all the plans? Why not? We also want to fix a hole from the No Surprises Act. In the Surprise Billing Act, which this committee discussed long and hard, Congress required health insurance agents and brokers in the private market to disclose how much money they were being insured. This type of sunshine helps consumers understand the incentives and determines what is the best insurance, health insurance for them and for their families. But unfortunately, Medicare Advantage was left out. Why? Why was Medicare Advantage left out? I haven't heard the answer to that question at all. Oh, wait, maybe somebody will speak up. Baloney. 1 in 3 Medicare beneficiaries turns to an agent or broker when making health care enrollment decisions. Unfortunately, these protections do extend to Medicare Advantage. CMS revealed earlier this year that the number of Medicare beneficiary complaints about private sector marketing for Medicare Advantage plans more than doubled from 2020 to 2021. Beneficiaries lack information on how brokers and agents winnow down plan options and the role financial incentives play in the advice to advise brokers and the advice that they give. If someone is getting a financial incentive or luxury trip to promote a particular plan, a senior deserves to know that. No different than someone who is under 65. Why? Oh, wait, 10 seconds for that. No reply. This shouldn't be a partisan issue. It wasn't partisan in the vote that we took a few years ago, and it isn't now. Those in the Medicare, who are in Medicare, deserve the same information and transparency as those who are in other insurance. This amendment should be easy to support. I yield back, Mr. Chairman. Thank you.
Does anyone else wish to speak on the amendment? Mr. Blumenauer? Proceed.
Thank you very much. I believe that Mr. Smith of Nebraska is absolutely right. He's gotten this amendment and this language on very short notice. And there's good reason for that, because it was on very short notice on Saturday that for the first time our staff learned that Medicare Advantage would be stripped out of this proposal. That was wrong. There is no justification. It's clear that once again a powerful insurance lobby has controlled what's happened here and not the best interest of the 32 million people that rely on Medicare Advantage. Yes, the proposal that I've advanced not only restores what was stripped out that the Commerce Committee approved, but I seek to strengthen it. Because as Mr. Pascrell has just pointed out, there is no coverage for agents and brokers that are promoting these Medicare Advantage plans. And let me just comment a little more about what that means. We hear that you can call the Medicare helpline, that you can go to Medicare.com, that you can turn to all kinds of help that's available. without explaining to the healthcare consumer, to the senior or individual with disabilities, that this is not something that's done on an objective, independent basis, that these are commercial ways of promoting Medicare disadvantage plans. And so they tell you about the gym membership you could get, the free groceries you might qualify for, everything but an autographed football from Joe Namath that you might qualify for, and they do not tell you anything about the limitations or the restrictions on the type of physicians and the type of coverage you have. And as a result, they mislead people into Medicare Advantage. All that this amendment would do is require disclosure that this supposedly independent broker operating under a misleading name, that they're hired by the insurance company. They're like a used car salesman. They're out there to sell. They're not necessarily out there to fully disclose. And I think that it is a mistake to not provide information. The used car salesman, it's clear who he or she works for. It's not clear who the broker in this case works for or how much compensation that they are getting. And this amendment would correct that. I believe that our seniors and individuals with disabilities tend to be some of the more vulnerable members of our society. They deserve the protection of transparency that this bill denies. And I believe that correcting it by including them, we've heard from one speaker after another the great value of transparency. I think it has some value, not nearly as much as has been advanced, but if it has so much value, why deny seniors and individuals with disabilities the right to have the same data? Not all of those people who are in Medicare Advantage go there willingly. I met with a group of people here yesterday, about 100 people who had been forced into a Medicare Advantage plan by their city government. They had no choice, but they're finding significant limitations when they need care in terms of prior authorization, a whole range of limitations that they were never told about when they got put in that plan, and they would not face if they were in traditional Medicare. So there may well be a place for private insurance. I wouldn't call it Medicare Advantage. I would call it private insurance for those who are eligible for Medicare. But there may be a place for that. But there ought to be full, transparent disclosure so that seniors and individuals with disabilities are treated just like everyone else under this bill. And there has been no reason of any type as to why that protection is not being provided. And that's why, unfortunately, the only solution today for those of us who believe in price transparency is to vote against the so-called Healthcare Price Transparency Act because it limits transparency instead of granting more protection. I yield back.
Does anyone else wish to speak on the amendment? Seeing none, the question is on agreeing to the amendment offered by Mr. Doggett. The clerk will call the roll.
Mr. Buchanan?
No.
Mr. Buchanan, no. Mr. Smith of Nebraska? Mr. Smith of Nebraska, no. Mr. Kelly? Mr. Kelly, no. Mr. Schweikert? Mr. LaHood? Dr. Winstrup? Dr. Winstrup, no. Mr. Arrington? Dr. Ferguson? Dr. Ferguson, no. Mr. Estes? Mr. Smucker? Mr. Hearn? Mr. Hearn, no. Mrs. Miller? Mrs. Miller, no. Dr. Murphy? Dr. Murphy, no. Mr. Kustoff? Mr. Kustoff, no. Mr. Fitzpatrick? Mr. Fitzpatrick, no. Mr. Stubbe? Mr. Stubbe, no. Miss Tinney? Miss Tinney, no. Mrs. Fishbach? Mr. Moore? Mr. Moore, no. Mrs. Steele? Mrs. Steele, no. Ms. Van Dyne. Ms. Van Dyne, no. Mr. Feenstra. Mr. Feenstra, no. Ms. Maliotakis. Ms. Maliotakis, no. Mr. Carey. Mr. Carey, no. Mr. Neal.
Yes.
Mr. Neal, yes. Mr. Doggett. Mr. Doggett, yes. Mr. Thompson. Mr. Thompson, yes. Mr. Larson. Mr. Larson, yes. Mr. Blumenauer. Mr. Blumenauer, yes. Mr. Pascrell. Mr. Pascrell, yes. Mr. Davis. Mr. Davis, yes. Ms. Sanchez. Ms. Sanchez, yes. Mr. Higgins. Mr. Higgins, yes. Ms. Sewell. Ms. Delbene. Ms. Delbene, yes. Ms. Chu. Ms. Chu, yes. Ms. Moore. Ms. Moore, yes. Mr. Kildee. Mr. Kildee, yes. Mr. Byer. Mr. Byer, yes. Mr. Evans. Mr. Schneider. Mr. Schneider, yes. Mr. Panetta. Mr. Panetta, yes. Mr. Schweikert. Mr. Schweikert, no. Mr. LaHood. Mr. LaHood, no. Mr. Arrington. Mr. Arrington, no. Mr. Estes. Mr. Estes, no. Mr. Smucker. Mr. Smucker, no. Mrs. Fishbach. Mrs. Fishbach, no. Ms. Sewell. Mr. Evans. Chairman Smith.
No.
Chairman Smith, no.
The clerk will report the vote.
The ayes are 16, the noes are 25.
There being 16 ayes and 25 noes, the amendment is not agreed to. Are there additional amendments? Mr. Pascrell's Mr. Pascrell?
Thank you.
Mr. Chairman, I reserve a point of order.
A reserve has been made. Would the gentleman suspend while the amendment is distributed?
Yes.
Mr. Pascrell, please proceed.
I have an amendment on this, Mr. Chairman. This bill that is in front of us today has many holes, as the discussions have brought out on both sides. If you listen to both the Democrats and the Republicans, this bill is lacking, particularly on the transparency provisions. My amendment outlines a series of common sense steps to increase transparency, to improve reporting, and empower consumers. Members, who were on this committee just 3 years ago, who still are here, will recognize the language, some of the language, since our committee reported this measure by voice vote 3 years ago. I want everybody to think about that, please. Not because it's this amendment, because of how things have changed. When it's no on every amendment. The octopus tentacles of private equity have wrapped across this country. Private equity has adversely impacted many industries, but it's quickly and dangerously expanding into the ownership of hospitals, physician practices, and perhaps most alarmingly, skilled nursing. These are facts, not because I say them. Look at the data. No one is against investment for private factors into healthcare. That's not what we're talking about. This is not a shot against the private market or competition or capitalism. Get that out of your head. That's propaganda. The common sense requirements in this amendment are recommended by many experts, Democrat and Republican, that have come before our committee. The amendment will help stop bad actors from hiding true ownership. That's what they did with the nursing home scandals. We sat and did nothing. Democrats and Republicans did very little. Very little. What's wrong with getting information out truly who owns the business? What's wrong with that? Tell me. Is that an attack on privacy? That's always, we always got our fingers in the air. Which way is the wind blowing here? The health entities that we're talking about have had their profits sucked out and deprive our communities of quality care. The amendment will also protect precious Medicare dollars and funds that are used to ensure our seniors receive the highest level of care. Let me just divert for 2 seconds. If I am campaigning, God willing, next year, all of us, we're campaigning, I'm going to bring this up. I'm going to tell seniors what you won't do. And you did. That's a two-step. We have been hamstrung by private equity for far too long. Stand up. It is time that we take real action to protect our constituents. I know no member will oppose the language that he or she previously supported. I urge my colleagues to support my amendment, and patients who have the right to know who really owns their health care provider. Wow. You want to clean up health care? You want to make it respond? I yield back, Mr. Chairman.
Mr. Hearn is recognized to speak on the amendment.
Thank you, Mr. Chairman. You know, once again, my Democrat colleagues, in the name of transparency, want to continue weaponizing the IRS against the American taxpayers. The Democrats supersized the IRS when they gave the agency a massive $80 billion infusion of taxpayer money to squeeze out more revenue out of Americans earning less than $400,000 a year. This is the agency that is conducting financial surveillance of Americans' Venmo transactions. This is the agency that is hiring 87,000 new agents for enforcement rather than fix their woefully inadequate customer service and call wait times. The IRS, an agency with a history of political targeting, is the last agency that should get the immense amount of sensitive financial information that would be required by this amendment. I just want to point out a couple of things in this great amendment. On page 6, line 13, it gives a blank check for the IRS to ask for more information. It says, quote, other information, such as other information as a secretary may reasonably require. On page 10, line 14, requires information to be reported publicly. It says, annual returns filed under this section shall be made available by the secretary to the public, as soon as practical in a machine-readable format. So this isn't just a harmless grab by the IRS. This is a way, to one more level of infiltration into the daily lives of American taxpayers. Now, while we don't agree on this amendment, the bill before us today was written with bipartisan input. I urge the committee to reject this amendment. I ask my Democrat colleagues to put aside the partisanship and join us with the support of our patients. Thank you. I yield back.
I recognize the ranking member.
Thank you, Mr. Chairman. I want to yield my time to the gentleman from New Jersey, Mr. Pascrell.
That's a good one. The IRS. Let's bring in the IRS now, because we voted on some money a few years ago, ladies and gentlemen, and members of this wonderful committee. We voted because we know the record from 2010 in the IRS and how many folks they needed, but how many folks they hired. What has that got to do with the price of tomatoes? What has that got to do with people's health care? Zippo. It doesn't tell me who owns the company. It doesn't tell me who's on first base. Thank you, Bud Abbott and Lou. It doesn't tell me who's up at bat next. It just is something we'll throw out there against government, against the IRS. They're all a bunch of bad guys looking to sneak in our pockets. How else are we going to collect the revenue, by the way, unless we have laws to do that? That's what is happening right now. You heard their response to this amendment, and you sitting in your seat, I don't care whether you're a Democrat, Republican, Polish, or Italian, you see a gimmick when you hear one, that's one. I'm embarrassed to respond to what you had to say about my amendment. I'd rather you say it stinks, throw it out, than talk about the IRS as being the culprit in all of this. Yes, it was a plot. I yield back right now.
Any further wish to speak? Mr. Doggett.
Thank you, Mr. Chairman. Thank you, Mr. Pascrell, for this important amendment. You know, it's not only the Medicare disadvantaged lobby of private insurance companies that can celebrate today that they will not have to provide any transparency to 32 million Americans. No, the private equity lobby has done pretty well here today too, because even the modest provisions in the Energy and Commerce Committee bill have been stripped out. And so, Mr. Pascrell, you're right that the tentacles of private equity spread across America, but they obviously also spread into this Congress and into this committee, because there is no justification for removing those private equity provisions, nor has there really been any justification advanced for not accepting your amendment. There is no aspect of American health care today that is untouched by private equity. Hospitals, provider groups, nursing homes, insurance companies, pharmaceutical companies, private equity plays a role in all of them. Over the last decade, private equity has invested nearly $1 trillion into health transactions. Acquisitions have soared, consolidation has followed, and so have prices. One study found that private equity-owned medical practices charge 20% more on average per insurance claim than independent medical practices. An estimated 80% of private equity-owned physician practices significantly increased prices after the takeover. So often that's the whole purpose. I've heard one Republican after another during the past year blame the Affordable Care Act that prices are rising. Well, yes, prices are rising, and there's a reason for it. Private equity has played a big role, and this Congress has played no role at all in trying to contain those price increases. These private equity takeovers often result in staff layoffs, particularly nursing staff, leading to reductions in the quality of care. In some nursing homes, this has literally been a matter of life and death. One egregious example, researchers found that post-nursing home discharge mortality rates, that is deaths, among Medicare patients increased by about 10% after private equity acquisition. That figure represents more than 20,000 lives that may have been lost because of these sudden staffing changes after private equity takeover. Meanwhile, we paid more to get less because the price to Medicare increased in overall spending because of private equity. Since 2013, private equity-owned health companies have paid more than $500 million to settle claims that they have overcharged taxpayers and government health programs. Again, so much talk about waste and fraud in programs, but not action to do something about it, and these settlements represent a fraction of the overall cost to our healthcare system in overcharging. While our colleagues on the Energy and Commerce Committee took bipartisan action to require detailed reporting on change of ownership, mergers, and acquisitions, and the many business holdings and dealings in the healthcare sector, Republicans on this committee have not offered a single policy to shed light on private equity shadowy practices. And let's make it clear again, we're not saying no private equity in this amendment. We're simply saying, tell us about it. Give us the information. The chairman has opened this discussion today by saying he doesn't want to leave consumers at the mercy of big corporations. Well, I don't either, but that's exactly what this bill does in excluding Medicare Advantage and excluding private equity. I'm concerned about the lack of oversight. I'm concerned about the physicians that I've been hearing from in Central Texas who face the threat of consolidation because of private equity. Private equity companies that come in and offer the moon, and often the moon and the sun are available to the most senior partners in that practice. But those who are also in the practice get very little, and the end result is consolidation, a lack of competition, and prices that soar upward. Numerous investigations continue to expose the harm caused by private equity. USA Today and Newsy found that private equity-required dental practices were pressured into providing unnecessary and expensive care, such as drilling teeth with no cavities and without even first taking an X-ray. Lower care, higher cost, at least give us the facts, and that's all that the Pascrell Amendment does. It should be adopted. I urge its approval.
Mr. Kelly's recognized.
Thank you, Chairman. And I appreciate Mr. Pascrell's passion on this, and he demonstrates that quite often. Let me just clear up, though, this amendment. The majority is going to sue. They've already made this idea they have to supersede the IRS because some people just aren't paying their fair share. I'm so sick of hearing about their fair share. $80 billion infusion of taxpayer money to squeeze out more revenue out of Americans earning less than $400,000 per year. I believe there's no greater invasive species in America today than the government. What don't they touch? What don't they tax? What don't they waste? And when do they ever quit? They don't. They don't. Now, a lot of these things get hit in these amendments, and some say, well, it's not. It's really, no, you're misinterpreting what it is. No, we're not. No, we're not. So we're going to start this reporting, and these numbers are going to be made available. So forget about the 6103. We've already forgot about that. You guys opened a Pandora's box a couple years ago when it came to what your action when it came to the former president's taxes. When does this stop? When does this stop? When can Americans actually lay their head on a pillow at night and understand that, you know what, you can go ahead and sleep through the night. There's not somebody out there who believes that you are a cheat. Look, I think, Mr. Pascrell, I think your intent is right. But unfortunately, we don't live in a world where intent is enough. I'm amazed at what we come up with from time to time, but I got to tell you, and I mean this sincerely, who isn't invading our privacy? Who doesn't have control of everything? Why in the world are we just so intent on we have to get to the bottom of this, and we have to get to the bottom of it today? And let's start at the bottom of the rung, because they are the most vulnerable, because they can't afford counsel to help them out. If you have not been through one of these questioning periods by the IRS, then God bless you. I got to tell you, if you think indigestion keeps you up at night, wait till these cats start working on you. They don't stop. They don't know when to stop, and I know my friends on the other side have gone through some of the same things. I would caution us, let's not get so caught up in some of these things that we don't see the reality of what is taking place in our country today. I mean, we all represent the same people. I don't really care how they vote. They vote any way they want. And you and I and all of us are here because we got one more vote than whoever it was running against us, and sometimes much more than one vote. But I will tell you this. The faith, the trust, and the confidence that the American people need to have in this system has been greatly strained. When I'm home, when I come out of Mass, when I stop to have a breakfast at a small restaurant, the same thing always comes up. When can we keep these people out of our lives? I would caution as we continue to push forward on this. I don't believe that all Americans try to cheat on their taxes because they don't want to pay their fair share, whatever that means, depending on who it is and how they declare what it is they actually have earned and what they pay taxes on. But gentlemen and ladies, we have an opportunity to do something today that makes sense for the American people. Is it perfect? Absolutely not. Could have this been handled in the previous Congress? Possibly, I don't know. But today we have a chance to do something that's right for the American people. If we can't start doing that with all the other little arguments we can have in between, and we should have them in-house, but I would just suggest that we shouldn't go out into the public and completely destroy everything that we've worked for. Chairman, I think you've done the right thing at the right time for the right reasons. If we can't do that, then what is it that we're capable of doing? But I would caution people, the most invasive species in our lives is not some insect or some animal or some chemical. It's our own government. They get too involved too often, and they go too far with it. Once you lose that faith, trust, and confidence, you don't gain it back. Mr. Chairman, thank you for bringing this forward, and for all our members, let's do the right thing for the right reasons, and we'll get the right results. Thank you so much. I yield back.
Chair yields to Mr. Davis.
To strike the last word. Both Mr. Doggett and Mr. Pascrell have made very compelling, but also very factual comments relative to the Pascrell amendment. I simply associate myself with both their comments, yield back, and yield the balance of my time to Mr. Pascrell.
Thank you. Thank you to the gentleman from Illinois. I can't believe.
I got it.
I can't believe what I heard. But I need to respond. Because that's what men do. And women. Mike, we've been honest with each other, if I may, through the chair. We've been always honest with each other. Once in a while, we even agreed on the weather. But the point of the matter is, you voted yes on these words, as I did, 3 years ago. You voted in good faith, as you usually do. But to sit there and say, here's the government again, they're coming up behind you, What I said in my amendment is either true or not true. You could agree with it or disagree with it. That we're still living in America, believe it or not. But don't sit there and tell me that I have an ulterior motive in introducing this amendment. You stated the facts as you did in 2020. What has changed since 2020 that I don't see? What am I missing? Has anything changed? The figures got worse. The figures got worse. We need an accounting. This legislation, this amendment rather, adds reporting requirements. You can go through all the recommendations I made in the amendments. It's reporting, and they could tell tales. That's how we got to the bottom of looking at the elder housing. Some people went to jail for that. It was only the tip of the iceberg. I want to know who owns that particular nursing home. You've asked questions about that yourself. Not in bad faith, in good faith. So, we wanted to add reporting requirements so we could figure out who the heck owns and where the money is going. That's why expenses are so high in nursing homes. You and I may not be afford to get somebody and a family into them. It's serious business. Where are they going to go? If I can't take care or you can't take care, where do they go? I think that's a legitimate question. Under the amendment, a reporting person, quote unquote, who directly holds an interest in a specified medical care provider must electronically file a separate annual information return to the IRS containing specified information relating to the gross receipts, very important, real estate, payments to related persons. These requirements capture revenue across Medicare, Medicaid, and private insurer revenue related to specified medical care providers. The bill requires information on specified medical care providers, related transactions involving debt and rental leases, their payments. And finally, this information reported will be made publicly available so that not only the public will know, my good friend from Pennsylvania, we will know. And we're doing this. We've investigated nursing homes. A prime example of what we're talking about here. I beg you, put somebody else's name on the amendment. But I beg you to protect us and to protect all those people receiving health care, not just the nursing homes. I think reporting is very important so we look at the facts and not conjecture. I don't conjecture, you don't conjecture. Thank you. I yield.
The chair recognizes Mr. Smith of Nebraska.
Mr. Chairman, I have concerns. In addition to the concerns already raised about giving the IRS huge new pools of data which could potentially be misused to inappropriately target audits for political purposes, I'm also concerned about the potential impact of the increased compliance burden in rural and remote areas of our country. The rural and remote hospitals in my district don't have huge compliance teams. In fact, many of the smallest offices only have one staff member who handles all compliance in addition to other responsibilities. Even if the reporting was targeted to owners instead of the providers themselves, the initial language would have inevitably increased the paperwork and compliance burdens for hospitals and healthcare providers. It is good to see that the potential negative impact that existed has been removed from this legislation, and I yield back. Thank you.
Chair recognizes Ms. Sanchez.
Thank you, Mr. Chairman. I am proud to co-sponsor Mr. Pascrell's amendment, and I urge my colleagues to include this critical legislation in the underlying bill. And I would ask my colleagues to please spare me all of the hysterics on the IRS and to focus in on the substance of what Mr. Pascrell's amendment does, which many of you voted for in 2020. This amendment would simply put the onus on private equity firms to report how much money their firm receives as reimbursement from providers for items or services under Medicare. That is, report their earnings from taxpayer dollars. Are we not concerned about where our taxpayer dollars go? Private equity's involvement in the healthcare industry has expanded rapidly over the past 20 years. The American Medical Association reported that in 2018, that was the first year in which more physicians were employees, 47.4%, than owners of their practices, 45.9%. In 1988, 72.1% of medical practices were owned by physicians. Studies this year has shown that private equity firms own more than half of all specialists in certain U.S. markets. We need additional transparency and data as to how private equity affects patient care and healthcare costs. To finance these purchases, private equity owners will load these companies with debt and slash costs to increase earnings, all within 3 to 5 years so that they can sell it off for profit. There is no room for long-term investment in this business scheme. Nursing homes are a prime example of how private equity's acquisition leads to a prioritization of profit over quality of care. And if my colleagues on the other side of the aisle are not concerned about quality of care, why don't you just say that? In practice, firms' investments force providers to increase the volume of patients seen, overprescribe tests and unnecessary procedures to drive reimbursement, and reduce staffing. This has a devastating effect on our nation's elderly. This is all because in the business of healthcare, the drive for profits runs counter to making the necessary long-term investments in patients. This hole in the underlying legislation is just one of the many issues with the legislation before us today that is bad. I urge my colleagues to adopt Mr. Pascrell's amendment and to ensure more transparency and reporting by private equity firms receiving taxpayer dollars. And I would also ask unanimous consent to enter into the record an article by the New York Times dated July 10th, 2023, Who Employs Your Doctor? Increasingly a private equity firm, with charts that show how much costs go up and patient care goes down when private equity firms are involved in the healthcare space. And with that, I yield back the balance of my time.
Ms. Chu is recognized.
I move to strike the last word. I rise in strong support of this amendment, which would address an inexplicable oversight in the underlying package by increasing transparency in how private equity firms are operating in the healthcare space. Private equity are investment firms fundamentally set up to increase profits for their shareholders, not to provide better quality medicine. The private equity business model is based on buying a company with the intent on selling off its assets and then selling again for a one-time profit. In healthcare, private equity deals have nearly tripled in value over the last decade, from $42 billion in 2010 to $120 billion in 2019, totaling $750 billion over the last decade. The fundamental principle of private equity to acquire and sell assets for maximum profit within 3 to 5 years is so clearly at odds with the goal of protecting patients and safeguarding taxpayer dollars in the Medicare program. In fact, a report just released last week revealed that private equity investment is associated with up to a 32% increase in costs for payers and patients. And a February 2021 study from the National Bureau of Economic Research found that going to a facility owned by a private equity firm increase the chance that a resident would die by 10% compared with living in another type of facility. I'm especially concerned with private equity's damaging effects on our nation's nursing homes. Private equity firms bought nearly 2,000 nursing homes from 1998 to 2008, with reports of diminishing quality following in the wake of these buyouts. Consider the case of Manor Care, a nursing home chain bought by the Carlyle Group. A 2018 Washington Post investigation found that after being bought by the Carlyle Group, health code violations rose 26% every year from 2013 to 2017 and included horrific negligence like neither preventing nor treating bed sores, medication errors, not providing proper care for people who need colostomies and prostheses, and not assisting patients with eating and personal hygiene. These are profit-based corporations, not healthcare companies, and our patients are suffering. Stories like these prove why it's so important for us to understand the financial obligations of private equity-owned healthcare companies, especially when there's such a large impact on quality of care for patients. I support this amendment as an important step in addressing the problem of private equity in healthcare. And I yield back.
Ms. Van Dyne is recognized.
Thank you very much, Mr. Chairman. I'm sitting here today after having chaired a meeting last week in small business that featured healthcare providers. And they were talking about how many healthcare providers are no longer able to have small solo practices or even small joint practices because of, not private equity, but because of the government's consistent intrusion on over-regulating them. I have had numerous roundtables in Texas District 24 with our doctors, and they have talked about over and over again, it is the over-regulation of government that is causing us to have to sell out and close our doors. I had a female doctor who sat there next to me, and she said, I got training, I had to go through medical school and get into debt. I know my patient's health history. I know who they are. I know when I give them medical advice, it is coming from a medical provider who knows them, talks to them, sees them. And yet I am constantly over-regulated by bureaucrats with no medical degree who have never even seen my patient. We are begging you for relief. I am no longer able to practice medicine. I am following protocol. We heard it all last week. I have heard it for a number of years now. If my Democrat colleagues, the gentlewomen from California, would like to work with me on ways of being able to save the very noble cause of private practitioners, I would love to work with you on it. But I'll tell you, it starts here with government overregulation, not with having access to necessary capital to be able to invest in their employees and their practices. And with that, Chairman, I yield back.
Does anyone else wish to speak on the amendment? Seeing none, the question is on agreeing to the amendment offered by Mr. Pascrell. The clerk will call the roll.
Mr. Buchanan?
No.
Mr. Buchanan, no. Mr. Smith of Nebraska? Mr. Smith of Nebraska, no. Mr. Kelly? Mr. Kelly, no. Mr. Schweikert? Mr. Schweikert, no. Mr. LaHood? Mr. LaHood, no. Dr. Winstrup? Dr. Winstrup, no. Mr. Arrington? Dr. Ferguson? Dr. Ferguson, no. Mr. Estes? Mr. Estes, no. Mr. Smucker? Mr. Smucker, no. Mr. Hearn? Mr. Hearn, no. Mrs. Miller? Mrs. Miller, no. Dr. Murphy? Dr. Murphy, no. Mr. Kustoff? Mr. Kustoff, no. Mr. Fitzpatrick? Mr. Fitzpatrick, no. Mr. Stubbe? Mr. Stubbe, no. Ms. Tinney? Ms. Tinney, no. Mrs. Fishbach? Mrs. Fishbach, no. Mr. Moore? Mr. Moore, no. Mrs. Steele? Mrs. Steele, no. Ms. Van Dyne? Ms. Van Dyne, no. Mr. Feenstra? Mr. Feenstra, no. Ms. Maliotakis? Ms. Maliotakis, no. Mr. Carey? No. Mr. Carey, no. Mr. Neal? Mr. Neal, yes. Mr. Doggett? Mr. Doggett, yes. Mr. Thompson? Mr. Thompson, yes. Mr. Larson? Mr. Larson, yes. Mr. Blumenauer? Mr. Blumenauer, yes. Mr. Pascrell? Mr. Pascrell, yes. Mr. Davis? Mr. Davis, yes. Ms. Sanchez? Ms. Sanchez, yes. Mr. Higgins? Mr. Higgins, yes. Ms. Sewell? Ms. Del Bene? Ms. Del Bene, yes. Ms. Chu? Ms. Chu, yes. Ms. Moore? Ms. Moore, yes. Mr. Kildee? Mr. Kildee, yes. Mr. Byer? Mr. Byer, yes. Mr. Evans? Mr. Schneider? Mr. Schneider, yes. Mr. Panetta? Mr. Panetta, yes. Mr. Arrington? Mr. Arrington, no. Ms. Sewell? Mr. Evans? Chairman Smith?
No.
Chairman Smith, no.
Clerk will report the vote.
The ayes are 16. The noes are 25.
There being 16 ayes and 25 noes, the amendment is not agreed to. Are there additional amendments?
Mr. Chairman, I have amendment at the desk.
Mr. Chairman, I reserve a point of order.
A point of order has been reserved. The clerk will distribute the amendment, and I ask the gentle lady to suspend while the clerk distributes. Proceed, Ms. Del Bene.
Thank you, Mr. Chairman. Mr. Chairman, my amendment would protect our nation's most critical, leading edge, and relied upon cancer hospitals from the Medicare reimbursement cuts that Republicans are proposing in this package. These cuts and the precedent they would set restrict access to cancer treatment for thousands of patients in my home state and millions of patients across the country. For decades, Congress has recognized the unique and essential role of cancer hospitals in treating patients following a cancer diagnosis and providing hope for families, which is in part why they have a different payment system in Medicare. These 11 dedicated cancer hospitals across the country are singularly focused on treating cancer patients, including rare, complex, and advanced stage cancers, and serve over 1 million patients annually. They also lead thousands of clinical trials and operate at the forefront of technology and new therapies. The Fred Hutch Cancer Center in my home state of Washington is one of the leading cancer and biomedical research centers and is the only dedicated cancer center not only in Washington state, but across the entire Pacific Northwest. Fred Hutch serves roughly 50,000 patients every year, including over 8,000 patients at the Overlake Cancer Center and Evergreen Health Community Clinics in my district. Most of Fred Hutch's services are performed in an outpatient hospital setting, including some of the most complex treatments, such as bone marrow transplantation and CAR T immunotherapy. Mr. Chairman, I ask unanimous consent to enter into the record a letter from the Fred Hutch Cancer Center highlighting the unique function that dedicated cancer centers play in treating cancer patients and spearheading cancer research.
Without objection.
Thank you. 10 other dedicated cancer centers across the country would be harmed by these cuts, such as the Moffitt Cancer Center in Florida, Memorial Sloan Kettering Cancer Center in New York, MD Anderson Cancer Center in Texas, and other life-saving cancer centers in Ohio, California, Pennsylvania, Massachusetts, and elsewhere. In the past, this committee has come together on a bipartisan basis to exempt cancer hospitals from broad-based Medicare payment changes. This situation should be no different. We should maintain this important precedent. I urge my colleagues to support this common sense amendment to protect cancer care and research and improve the underlying bill. I yield back.
Mr. Smucker is recognized to speak on the amendment.
Thank you, Mr. Chairman. I speak in opposition to this amendment, and I want to thank Ms. Delbene for bringing up the issue of the cancer hospitals, which are really important for the fight against cancer and to treat those with cancer. But I do want to point out that this bill already offers cancer hospital facilities a one-year delay before beginning to transition to payment parity. And I think it's a fair compromise, offering those facilities some extra time to plan while still delivering low costs for seniors. We should be working together to make health care more affordable for all seniors, and the underlying bill already does that. This amendment, however, would erode those patient savings, making it more expensive for seniors receiving cancer treatments. Our bill lowers costs for patients by aligning payments across the system. So we're paying for the services that are provided instead of where those services are provided. So it's a common sense proposal in this bill that has wide-ranging support. MedPAC has recommended Congress move in this direction several times in the last decade. And in fact, both President Obama and President Trump included reforms to improve payment parity across settings of care in their own budgets. Groups across the ideological spectrum have also supported these payment reforms because they lower costs for patients. This is groups from the Committee for a Responsible Federal Budget, Americans for Prosperity, to Families USA and the Progressive Policy Institute. While Congress did go back and exempt cancer hospitals from the site-neutral payment policy passed in 2015, that exemption was paid for with a corresponding cut to these cancer hospital facilities. When the Trump administration aligned payments across settings for office visits, a policy that was continued under the Biden administration, it applied to all facilities, not just some. Additionally, early feedback from the CBO suggested that a full exemption of cancer hospitals could have a significant disproportionate impact for an exemption that would only apply to 11 cancer hospitals. These specially designated cancer hospitals also already get other special treatments in the Medicare payment system, which are designed to compensate for the challenges they face delivering care for their unique patient population. So again, I think the current policy in the bill, it's a fair compromise, and I encourage my colleagues to vote against raising costs for seniors and against this amendment. Thank you, Mr. Chairman. I yield back.
Ms. Chu is recognized.
I move to strike the last word. I rise in strong support of this amendment, which would exempt cancer centers from site-neutral payment requirements. Cancer hospitals provide individualized, life-saving treatment for patients across the country. This is especially true for patients that have exhausted all other conventional care options, are appropriate for clinical trials, and for patients with complex cases for which there's no standard treatment option available for them in community settings. And the patients that cancer hospitals treat are sicker, have more chronic conditions, are more likely to become hospitalized, and are at increased risk of death. These patients are also more likely to have metastatic disease, be people of color, be duly eligible for Medicare and Medicaid, and have higher comorbidity risk scores. For example, City of Hope a cancer center headquartered near my district, is currently treating a patient who has been diagnosed with acute lymphoblastic leukemia. And he came to City of Hope because no one else in the community could care for him. Over the course of 15 years, he's been treated with both inpatient and outpatient intensive chemotherapy. He unfortunately relapsed after treatment and was placed on an outpatient clinical trial of a novel treatment, nelarabine, remission. Luckily, he underwent cord blood transplantation at City of Hope and is now free of leukemia. During this time at City of Hope, he received various types of support not available in the community setting, including social work, family support groups, and genetic counseling and testing. He's since undergone repetitive distress screening in clinics where he was found to have a neuropathy that has responded well to treatments delivered by a multidisciplinary team, and he undergoes survivorship screening and monitoring. If cancer centers like City of Hope are not compensated for the costs they incur to maintain facilities that can treat any type of cancer patient, offering these critical life-saving services would not be possible. Unfortunately, the underlying bill completely overlooks this reality and would undermine the ability for these facilities to offer specialized care to the patients that need it most. I urge my colleagues to support this amendment, and I yield back.
Mr. Pascrell is recognized to speak on the amendment.
Mr. Chairman, I support this amendment. Congress bipartisanly excluded cancer hospitals from Medicare site-neutral cuts in 2016. We have short memories. This amendment maintains this bipartisan agreement. Cancer hospitals are paid differently in Medicare because of their different cost structures and missions. This amendment, and thank you, Ms. Delbene, this amendment maintains their exemption from site-neutral payments, correct? That's already in effect. And that the cancer hospitals already paid for with the reduction in their Medicare payments. So I think that what we're doing today on these amendments, I hope is not predictable. I hope we just look at the facts. And we'll stay here all day to discuss this. That's how I think it's significant what we're doing today, or what we're dealing with. And I thank the chairman for bringing this up. But this is like a Swiss cheese, too many holes. Can't deny the facts, Mr. Chairman. You can have your perception, but you cannot deny the facts. I yield back.
I recognize myself to speak on the amendment. The energy and commerce piece of legislation that so many of our counterparts on your side of the aisle that has praised, there is no exemption whatsoever for cancer hospitals. Not one, but you all praised it, and every Democrat of energy and commerce voted for it. So we are actually fixing it in this piece of legislation. We're granting at least a year phase-in. A year phase-in. The energy and commerce package that everyone on this committee thought that we should have just picked, not everyone, the Democrats on this committee thought we should have just picked up and let the energy and commerce steamroll us, it completely exempted it. So what we have in this bill is better than the energy and commerce. And also, site neutrality is extremely important about future access. And we are going to be addressing that in this committee because there are healthcare deserts throughout this country because if you live in the big cities, you get paid more for healthcare. But if you live in a rural area, you get paid less. And guess what? Healthcare follows the money. And we're going to make sure that all Americans are treated the same, whether they live in a rural congressional district or whether they live in an urban congressional district. Ms. Moore, you are recognized.
Thank you so very, very much, Mr. Chairman. And I just want to note your comment at the beginning of this hearing, where you said that our biggest complaint on this side was what was not in the bill. And you absolutely are accurate. My thing is if you're going to be transparent, you can't have transparency unless you have transparency with the entire healthcare system and not just carve-outs for Medicare Advantage, private equity, and beneficiary assistance. That being said, I strongly support Ms. Delbenny's amendment. I think it's bad enough that this site-neutral payment policy makes cuts to hospitals in general, hospitals in rural areas, urban areas, period. Hospitals are, as we all know, do not receive adequate payment under Medicare as it is. So to say that we're going to increase transparency somehow by cutting hospitals is just a non sequitur. As a survivor of cancer who's had chemotherapy and radiation, I want to say that I have a great deal of knowledge that I didn't have before about the necessity of preserving sites for cancer treatment. They're very specific. This is not the factory where you're going in and getting your radiation or chemotherapy or getting your treatment. All of these treatments are very, very specific and specialized. And to say that you're going to reimburse them the same way you would, say, a community-based urgent care center or something where they stabilize you before they take you to the hospital it's just not fair or reasonable to the patients, the employees. It just doesn't add up mathematically. I do want to say that it's such a privilege to serve on this committee, and I think that we could have enjoyed this more if people like Ms. Delbenny, like Ms. Chu, people like Mr. Doggett, people who are really focused and dedicated on this aspect of it had been in the room where it happened when you were putting this together. I would have been much more inclined to support this bill. But I didn't intend to speak up, but I just couldn't resist mentioning the real service that cancer centers provide. And I just can't imagine what would have happened in my own personal situation had the cancer center in my area been reduced to raking and scraping up resources to treat me. And with that, Mr. Chairman, I would yield back and thank you so much.
Does anyone else wish? Ms. Sanchez is recognized.
Thank you, Mr. Chairman. I wish to associate myself with the remarks of my colleague, Ms. Moore, and yield the balance of my time to Ms. Delbenny.
Thank you. Just want to be clear, this amendment is maintaining the precedent that has been set by Congress for decades. 1 year does not help our hospitals. You're still you're still increasing their costs, and cancer hospitals have a different payment system in Medicare than other facilities, as I brought up earlier, and have a very specialized mission and have lots of costs associated with that in terms of the work they do on new therapies, clinical trials, and dealing with the most complex patients. So a 1 year delay is not an answer. This has been bipartisan. Absolutely, I encourage my colleagues to make sure that we support our cancer centers and support the amendment, and I yield back.
Does anyone else wish to speak on the amendment? Seeing none, the question is on agreeing to the amendment offered by Ms. Delbenny. The clerk will call the roll.
Mr. Buchanan?
No.
Mr. Buchanan, no. Mr. Smith of Nebraska? Mr. Kelly? Mr. Kelly, no. Mr. Schweikert. Mr. Schweikert, no. Mr. LaHood. Dr. Winstrup. Dr. Winstrup, no. Mr. Arrington. Dr. Ferguson. Mr. Estes. Mr. Estes, no. Mr. Smucker. Mr. Smucker, no. Mr. Hearn. Mr. Hearn, no. Mrs. Miller. Mrs. Miller, no. Dr. Murphy. Dr. Murphy, no. Mr. Kustoff. Mr. Kustoff, no. Mr. Fitzpatrick. Mr. Fitzpatrick, no. Mr. Stubbe. Mr. Stubbe, no. Miss Tinney. Miss Tinney, no. Mrs. Fishbach. Mrs. Fishbach, no. Mr. Moore. Mr. Moore, no. Mrs. Steele. Mrs. Steele, no. Miss Van Dyne. Miss Van Dyne, no. Mr. Feenstra. Mr. Feenstra, no. Miss Maliotakis. Miss Maliotakis, no. Mr. Carey. Mr. Carey, no. Mr. Neal. Mr. Neal, yes. Mr. Doggett. Mr. Thompson. Mr. Thompson, yes. Mr. Larson. Mr. Larson, yes. Mr. Blumenauer. Mr. Blumenauer, yes. Mr. Pascrell. Mr. Pascrell, yes. Mr. Davis. Mr. Davis, yes. Miss Sanchez. Miss Sanchez, yes. Mr. Higgins. Mr. Higgins, yes. Miss Sewell. Miss Delbene. Miss Delbene, yes. Miss Chu. Miss Chu, yes. Miss Moore. Miss Moore, yes. Mr. Kildee. Mr. Kildee, yes. Mr. Byer. Mr. Byer, yes. Mr. Evans. Mr. Schneider. Mr. Schneider, yes. Mr. Panetta. Mr. Panetta, yes. Mr. Smith of Nebraska. Mr. Smith of Nebraska, no. Mr. LaHood. Mr. LaHood, no. Mr. Arrington. Mr. Arrington, no. Dr. Ferguson. Mr. Doggett. Ms. Sewell. Mr. Evans. Chairman Smith.
No.
Chairman Smith, no.
How is Mr. Ferguson recorded?
Dr. Ferguson is not recorded. Dr. Ferguson, no.
Clerk will report the vote.
The ayes are 15, the noes are 25.
There being 15 ayes and 25 noes, the amendment is not agreed to. Are there additional amendments? Ms. Chu. Ms. Chu?
Mr. Chairman, I reserve a point of order.
There has been a point of order reserved. The clerk will distribute the amendment, and I ask the gentle lady to suspend while the clerk distributes. Ms. Chu, proceed.
Oh, he did? Mr. Chair, I wish to offer an amendment. I am concerned that today's efforts to increase transparency in our healthcare system miss the mark. We are seeing proposals that would exempt some of our nation's biggest corporations from oversight and transparency, and yet patients are not given the same consideration when it comes to our data privacy. My amendment would ensure that nothing in this bill may be used or disclosed for the purposes of prosecuting or investigating a patient who is exercising their federal rights to health care or a provider who is engaged in providing comprehensive sexual and reproductive health care. Frankly, Mr. Chair, I wish I did not have to offer this amendment today. But since the Supreme Court's decision to overturn Roe v. Wade, we've seen unprecedented criminalization of pregnant women and the providers who care for them. Just last week, attorneys general from 18 states, led by Mississippi, made the case that a person's private medical records should be available to state authorities. They want to do this because they want to be able to persecute women who have managed to travel out of state to receive abortion care. So not only are they banning abortion in their own states, but now they are criminalizing women who seek to get that care out of state. This is already happening. This month, a teenager in Nebraska was sentenced to jail for using medication to terminate her pregnancy. What's more, we know that the rapidly changing landscape surrounding abortion care has made more physicians and providers in states afraid to perform the full range of obstetric care for fear of prosecution. In fact, a recent lawsuit filed in Texas by providers and patients argues that Texas physicians are often too terrified to perform likely legal abortions because the consequences of performing an abortion that the courts later deem to be illegal are catastrophic. In Texas, the maximum penalty for performing an illegal abortion is life in prison. And we've seen this impact that the lack of clarity has had. Patients like Amanda Zarowski, who was forced to continue an unviable pregnancy until she developed sepsis. Her family flew to her bedside because for hours it was unclear whether she would live. While she ultimately survived, Amanda developed severe scar tissue on her uterus. She lost a fallopian tube. It's unclear if she will ever be able to carry another child, all because her doctors were terrified to give her the care she needed. My amendment will simply clarify that nothing in the underlying bill cannot be used to go after physicians so they can do their jobs and care for their patients. This is the reality we are living in. I know my colleagues on the other side of the aisle will argue that these bills have nothing to do with reproductive rights. But if there's one thing we have learned in the past year, it is that unless we go out of our way to proactively protect the data and lives of patients, they and their doctors will be subject to prosecution by extreme anti-choice politicians. I urge my colleagues to support this amendment, and I yield back.
Does anyone else wish to speak on the amendment? Seeing none, the question is on agreeing to the amendment offered by Ms. Chu. Clerk, please call the roll.
Mr. Buchanan?
No.
Mr. Buchanan, no. Mr. Smith of Nebraska? Mr. Kelly? Mr. Kelly, no. Mr. Schweikert? Mr. LaHood? Mr. LaHood, no. Dr. Winstrup? Dr. Winstrup, no. Mr. Arrington? Mr. Arrington, no. Dr. Ferguson? Dr. Ferguson, no. Mr. Estes? Mr. Estes, no. Mr. Smucker? Mr. Smucker, no. Mr. Hearn? Mr. Hearn, no. Mrs. Miller? Mrs. Miller, no. Dr. Murphy? Dr. Murphy, no. Mr. Kustoff? Mr. Kustoff, no. Mr. Fitzpatrick? Mr. Fitzpatrick, no. Mr. Stubbe? Mr. Stubbe, no. Ms. Tinney? Ms. Tinney, no. Mrs. Fishbach? Mrs. Fishbach, no. Mr. Moore? Mr. Moore, no. Mrs. Steele? Ms. Van Dyne? Ms. Van Dyne, no. Mr. Feenstra? Mr. Feenstra, no. Ms. Maliotakis? Ms. Maliotakis, no. Mr. Carey? Mr. Carey, no. Mr. Neal? Mr. Neal, yes. Mr. Doggett? Mr. Thompson? Mr. Thompson, yes. Mr. Larson? Mr. Larson, yes. Mr. Blumenauer? Mr. Blumenauer, yes. Mr. Pascrell? Mr. Pascrell, yes. Mr. Davis? Mr. Davis, yes. Ms. Sanchez? Ms. Sanchez, yes. Mr. Higgins? Mr. Higgins, yes. Ms. Sewell? Ms. Delbene? Ms. Delbene, yes. Ms. Chu? Ms. Chu, yes. Ms. Moore? Ms. Moore, yes. Mr. Kildee? Mr. Kildee, yes. Mr. Byer? Mr. Byer, yes. Mr. Evans? Mr. Evans, yes. Mr. Schneider? Mr. Schneider, yes. Mr. Panetta? Mr. Panetta, yes. Mr. Smith of Nebraska? Mr. Smith of Nebraska, no. Mr. Schweikert? Mr. Schweikert, no. Mrs. Steele? Mrs. Steele, no. Mr. Doggett? Ms. Sewell? Chairman Smith?
No.
Chairman Smith, no.
Clerk will report the vote.
The ayes are 16, the noes are 25.
There being 16 ayes and 25 noes, the amendment is not agreed to. Are there additional amendments? Mr. Byer.
Mr. Chairman, I reserve a point of order.
There has been a point of order reserved. The clerk will distribute the amendment, and I ask the gentleman to suspend while the clerk distributes. Mr. Byer, proceed.
Thank you, Mr. Chairman. Mr. Chairman, I'm offering my amendment on the All Payer Claims Database, or APCDs. This hearing is all about healthcare transparency, and with that goal of lowering costs through increased transparency. And this is exactly what all payer claims databases do through claims data. We've already seen APCDs be incredibly successful at the state level, bipartisan state levels, and it's been in a bipartisan effort all the way. Some use APCD data to create consumer-facing price transparency tools that allow patients to compare the prices charged by competing providers. Others examine specific issues of current interest, such as opioid prescribing patterns and utilization of low-value services. Minnesota used payer-submitted information within the state's all-payer database to find a $2 billion cost savings opportunity in 2015. At the time, claims data allowed Minnesota to determine that 1.3 million hospital and emergency department visits were unnecessary, and that 2 out of 3 emergency visits could have taken place in a less expensive setting, such as a primary care provider or an urgent care center. All payer claims databases allow payers, providers, and regulators to analyze health insurance claims
from millions of beneficiaries to learn where spending is directed. These databases can give state policymakers, private payers, and academics critical data that inform decisions about healthcare costs and quality, including health and payment reform changes, care delivery design, transparency, population health, and policy and budget development. My amendment does two things. First, it continues to support state APCDs. If your state already has an APCD, the money can be used for maintenance or an innovative project. Something the state has outlined can reduce costs. But if your state doesn't have an APCD, this money can be used to stand that up. This bill then supports a national all-payer claims database. And this is the work that HHS has already started to do, looking at how to create regional databases, so it just codifies that effort. But it also allows HHS to contract out this work should they not want to do it in-house. They can allow a nonprofit experienced in this work to manage it. But the most important aspect of this bill is that it finally allows full access to all federal claims data, which is not the case currently. We complain in this committee all the time about the federal debt and deficit, and we know that Medicare is a major contributor to that. As a former business owner, I know it's important to understand your cash flow and all the data. And this is what it does. It gives us the ability to have full transparency over our cash flow and then be able to make decisions about that. There's nothing more fundamentally important to transparency than claims data. I understand that many of my Republican colleagues are welcome to working with us on APCD, and I look forward to working with them and respecting potential germaneness amendments. Mr. Chairman, I withdraw the amendment.
Thank you, gentlemen. Are there further additional amendments? Seeing none, the question is on the adoption of the amendment and the nature of a substitute. All those in favor signify by saying aye.
Aye.
Those opposed, no.
No.
In the opinion of the chair, the ayes have it and the amendment in the nature of a substitute is agreed to. I will now recognize Mr. Buchanan for the purpose of offering a motion.
Mr. Chairman, I move that the committee favorably report H.R. 4822 as amended to the House of Representatives.
The question is on the motion to favorably report H.R. 4822 as amended to the House of Representatives. The clerk will call the roll.
Mr. Buchanan. Mr.
Yes.
Buchanan, yes. Mr. Smith of Nebraska. Mr. Smith of Nebraska, yes. Mr. Kelly. Mr. Schweikert. Mr. Schweikert, yes. Mr. LaHood. Mr. LaHood, yes. Dr. Winstrup. Dr. Winstrup, yes. Mr. Arrington. Mr. Arrington, yes. Dr. Ferguson. Dr. Ferguson, yes. Mr. Estes. Mr. Estes, yes. Mr. Smucker. Mr. Smucker, yes. Mr. Hearn. Mr. Hearn, yes. Mrs. Miller. Mrs. Miller, yes. Dr. Murphy. Dr. Murphy, yes. Mr. Kustoff. Mr. Kustoff, yes. Mr. Fitzpatrick. Mr. Fitzpatrick, yes. Mr. Stubbe. Mr. Stubbe, yes. Ms. Tinney. Ms. Tinney, yes. Mrs. Fischbach. Mrs. Fischbach, yes. Mr. Moore. Mr. Moore, yes. Mrs. Steele. Mrs. Steele, yes. Ms. Van Dyne. Ms. Van Dyne, yes. Mr. Feenstra. Mr. Feenstra, yes. Ms. Maliotakis. Ms. Maliotakis, yes. Mr. Carey. Mr. Carey, yes. Mr. Neal. Mr. Neal, no. Mr. Doggett. Mr. Doggett, no. Mr. Thompson. Mr. Thompson, no. Mr. Larson. Mr. Larson, no. Mr. Blumenauer. Mr. Blumenauer, no. Mr. Pascrell. Mr. Pascrell, no. Mr. Davis. Mr. Davis, no. Ms. Sanchez. Ms. Sanchez, no. Mr. Higgins. Mr. Higgins, no. Ms. Sewell. Ms. Delbene. Ms. Delbene, no. Ms. Chu. Ms. Chu, no. Ms. Moore. Mr. Kildee. Mr. Kildee, no. Mr. Byer? Mr. Byer, no. Mr. Evans? Mr. Evans, no. Mr. Schneider? Mr. Schneider, no. Mr. Panetta? Mr. Panetta, no. Mr. Kelly?
How is
Ms.
Mr.
Sewell?
Kelly recognized?
Mr. Kelly is not recorded. Mr. Kelly, yes. Ms. Sewell? Ms. Moore? Chairman Smith?
Yes.
Chairman Smith, yes.
Clerk will report the vote.
The ayes are 25, the noes are 16.
There being 25 ayes and 16 noes, the motion is agreed to and H.R. 4822 as amended is ordered favorably reported to the House. Without objection, I ask that staff be authorized to make technical and conforming changes to H.R. 4822 and that members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. Our next order of business is H.R. 3284, the Providers and Payers Compete Act. I'm pleased to recognize the gentleman from Georgia, Dr. Ferguson, for an opening statement.
Thank you, Mr. Chairman, and I'd first like to thank Representative Burgess from Texas for his work on this bill, the Providers and Payers Compete Act, and also thank you again for including it in today's markup, Mr. Chairman. As it stands, the American healthcare system has allowed vertically integrated healthcare corporations to penetrate its fabric at every level. Not only does the current level of consolidation within our healthcare system increase costs of care for patients, but it also decreases patient access to already expensive treatments. This, as we all know, has a hugely negative impact on rural providers and patients. As vertical integration leads to less competition in the marketplace, patients will continue to lose the agency they once had over their healthcare decisions. We must put the necessary safeguards in place so that patient choice is not compromised and families receive the maximum value from their health care dollars. The Providers and Payers Compete Act will empower HHS to put a halt to these practices, which undoubtedly are harmful to public health. A couple of things to point out here. 3 PBMs, pharmacy benefit managers, control 80% of the prescription market. 85% of metro areas have a highly concentrated PBM markets, and hospitals are dominated by a few regional and national healthcare systems. More than 1,800 hospital merger announcements have occurred over the past 2 decades. In short, competition is not, the kind of competition we need in healthcare does not exist, and vertical integration of the healthcare delivery system is at the core root of the problem. So I look forward to the debate, discussion, and support of this piece of legislation. Mr. Chairman, I yield back.
Thank you. I now recognize the ranking member for his opening statement.
Thank you, Mr. Chairman. The gaps in the first bill render the task in the present bill more difficult. As we have just seen, our colleagues on the other side of the aisle apparently don't want to provide HHS and other regulators with the proper information they need to conduct real assessments. Our regulators, HHS, FTC, IRS, and others, should be looking both to consolidation and vertical integration to protect consumers. However, to do that, they need data, and our Republican colleagues have shown they're not willing to give the regulators what they need to do their job. Their solution,
omits key data to understand which providers are being purchased by which entities and which providers are related to common parent companies. Once again, the majority is siding with the powerful and the well-connected, putting the profits ahead of workers, seniors, and families. The bill is a token with no real teeth behind it. Our time would be much better spent giving regulators the tools they need to conduct robust oversight and making patient-focused improvements that expand access to quality, affordable health care for all members of the American family. With that, Mr. Chairman, I yield back my time.
Thank you. The committee will now proceed to consideration of H.R. 3284, the Providers and Payers Compete Act. Without objection, the measure will be considered as read and open for amendment at any point. At this time, I offer an amendment in the nature of a substitute, which was distributed in advance along with a green sheet explaining it. Without objection, the amendment in the nature of a substitute shall be considered as read, open for amendment at any point, and considered base text for purpose of amendment. I will now turn to Patrick Dumas, Staff Director for the Health Subcommittee, to provide the technical description of the amendment in the nature of a substitute with an emphasis on the changes made since introduction. I ask that members hold their questions until after his presentation.
Thank you, Chairman Smith, Ranking Member Neal. H.R. 3284, the Providers and Payers Compete Act, contains 3 sections. Section 1 provides for the short title of the bill. Section 2 requires the Department of Health and Human Services to report annually on how various Medicare payment schedules and rulemaking may impact healthcare consolidation, and requires public comment on such rules' impact. The amendment in the nature of a substitute subjects the provisions, rules, and payment schedules under Medicare Part A as well. Section 3 amends Section 1115A-B-4A of the Social Security Act to require the Center for Medicare and Medicaid Innovation to evaluate the impact tested models may have on healthcare consolidation. This concludes the technical walkthrough, and I look forward to answering any questions you may have.
Thank you. We will probably, I think it's probably best to break right now, recess. We have votes, they've been called, and upon the votes ending, we'll start up with technical questions with Mr. Doggett. All right, thank you. Committee will come to order. We are in technical questions about the amendment in the nature of a substitute, and I recognize Mr. Doggett for technical questions.
Well, thank you very much, Mr. Chairman. Can we get order here? Yeah. Thank you very much, Mr. Chairman. In posing my technical questions, I just want to agree 100% with what Dr. Ferguson said in opening up, that when we have less and less competition, we have more and greater prices, and when we have more vertical integration, there are less consumer choice, and that's what we need to be tackling. And my technical questions are about what this bill does to achieve that very important objective. You're going to have the Secretary of Health and Human Services write a report. Is that what this bill does?
Section 2 of this bill does require the Secretary to write a report.
And what are the major legal barriers or restrictions that are preventing the Secretary from writing a report without this bill?
I am not aware of any of those barriers, but
Okay.
the Secretary currently does not issue this report.
All right. Well, has a request been made to him? I mean, he was right here in this room earlier in the past week giving a speech. Has anybody asked him to prepare a report of this type?
Section 2 of this bill does require a
Right.
report
I mean,
from the
without
Secretary.
passing a bill, has there been any request of any kind, a letter, anything just saying, how about a report on the impact of consolidation?
I believe that's outside the scope of a technical question, sir.
All right. Can we agree if technically that any report that he will write will only be as good as the data that he has to write the report about?
And included in Section 1 of this report, it requires the Secretary to solicit and receive public feedback from stakeholders on this so that they will be well informed in making their report.
That means he can ask a lobbyist for a private equity company for the information, but the information is not compelled and not certain to be available, right?
Any public stakeholder is welcome to provide
Right.
feedback.
So if we're going to have a bill that does more than allow the Secretary to just ask a lobbyist for the data, it would seem to me that that data has to be available, and the first bill did not provide any data about private equity. Does this bill provide the Secretary any data about private equity upon which to base the report that he hasn't been asked to write, but we would now compel him to write with this bill?
In addition to what public stakeholders may provide, the Secretary does have access to all available data available to him or her, including that of ownership of healthcare entities that healthcare entities are required to submit to the Secretary under current law.
Well, certainly, I agree that he has the same access to publicly available data that any of us do, but you do not provide him any additional data in this bill, do you? Is there any provision of additional data?
There is no additional reporting required in this bill.
And the first bill we just had the committee approve on a completely partisan vote denied new data about private equity, didn't it?
The first bill did include a provision that required Medicare Advantage organizations to report currently unreported information to the Secretary
Well, I'm
relating to ownership.
I'm going to Medicare Advantage next, but on private equity, because Mr. Pascrell's amendment was rejected and the Energy and Commerce unanimous proposal on private equity was rejected, there's no new data that the Secretary will have on private equity that wasn't available for years past.
HHS does require certain ownership information to be reported
Okay,
currently.
we can stipulate to that, but you have not provided any additional data in either of these bills about private equity on which he could base a report.
There is no explicit information.
And as far as Medicare Advantage is concerned, with the exception of the one reference that you made, as far as any of the problems that Dr. Ferguson referred to on vertical integration, where, say, one insurance company has a Medicare Advantage, they have the pharmacy benefit manager, they own the medical practice, they have the nurses that would go out and do the in-home assessments, there is nothing that is new to the Secretary for preparing a report about that in this bill or the previous one, is there?
For this bill before us, it does require public stakeholder input on
I understand
horizontal
you can
integration.
call the lobbyist. I think the lobbyist didn't need to be called to influence the way the last bill was written. They came of their own accord. But the Secretary can call the lobbyist, can call academics, can call anyone else. But in terms of our providing him information on which to base a meaningful report about the way competition is being stymied by consolidation, by vertical integration. We're not giving him any new tools with which to do that, are we?
The Secretary can use all available data available to him.
Well, I guess we can agree to that, and I accept that as a no. Thank you very much.
Mr. Schweikert is recognized to strike for technical questions.
Technical questions. Thank you, Mr. Chairman. Walk me through this because I want to make sure I'm tracking. Are there any restrictions in this legislation for what HHS Secretary or their team can access? Can they buy commercially available market intelligence data?
No provisions in this bill change any restrictions that they may currently be subject to.
Okay, so if the Secretary wanted to do a hierarchical, here's where there's consolidation, here's where there's vertical integration, here's where these things, because we all know, we don't talk about it enough, that there's huge amounts of this sort of data available. You may have to subscribe to it, you may have to pay for it, but there's no restriction in here saying that the HHS Secretary can't just purchase the commercially available data for designing this report.
Correct. There's no restriction, and the Secretary may look to that data and work with contractors of HHS and CMS to provide that data if they so choose.
In the language for producing the report, is it agnostic, coming back saying, okay, here's where we find a market impairment for consolidation, but also here's where we find a market impairment for vertical integration? I mean, the report will, there's nothing in this language that sort of prescribes saying you're looking for a sinner. They also might come back to us and say this is actually produced pricing efficiency.
Correct. The Secretary has the liberties to interpret the information and base a report both on vertical or horizontal or other integration in the provider and payer space.
Okay, Mr. Chairman, last bit of this. And when you say interpret, it's the math is the math. It's if this vertical over here has actually created some price efficiency, or it will say that if over here it's actually caused a cost driver from concentration of a medical system, it will say that.
Very likely, yes, sir.
All right. With that, I yield back.
Further technical questions? Seeing none, we'll move to strike the last word. Those to wish to strike the last word. Mr. Doggett is recognized to strike the last word.
Mr. Chairman, I reserve a point of order.
What are you reserving a point of order to my comments, or?
I think I actually might take that reservation. Mr. Doggett.
I accept. Well, I think the answers and the non-answers really tell the story of this whole bill. It's basically a do-nothing bill. If the desire was to have the Secretary go to the media and call in the lobbyists and ask them for their advice about this matter, they could have done that. And this bill gives no new data. The last bill gives no new data. The Pascrell Amendment would have given some new data concerning the way that private equity is taking over healthcare and producing soaring costs. It would have given some data to show the vertical integration that is occurring. Some of that information is available to the Secretary. Some ownership information is available to the Secretary now. He could have made a limited and incomplete report based on the information that is available from public sources and lobbyist advice. But if we're to get a complete, thorough report about the pernicious effect of over-consolidation, vertical integration, and what that cost Americans in terms of higher payment to Medicare, to our healthcare system generally, he needs some data on which to base that report. And that data is missing here because the committee, a majority of the committee has chosen to protect private equity from any disclosure, from any transparency, and thereby to avoid the potential for lower costs to taxpayers, and in the case of nursing homes and some other healthcare facilities, better care for those who are affected. The same thing is true with reference to Medicare Advantage. There is some data that's available, but we would have gotten more about the impact of what is vertical integration now, where one company controls the entire healthcare chain. And when that happens, you can have unnecessary referrals by that company from one subsidiary to another subsidiary. They make more money that way, and taxpayers face more cost. This is another example of where there is so much talk about eliminating waste, fraud, and abuse to pay for everything in government. But when it comes to doing the hard work of identifying specific areas where waste, fraud, and abuse is occurring, and this is one of them, the majority refuses to take the action necessary. We would not have solved all the problems of private equity or Medicare Advantage by adopting the amendments we advanced earlier, but we would have at least given a few more facts for writing a report like this, or a day when a future Congress has the courage to stand up for American healthcare consumers, to see that they get better, more comprehensive care, and that taxpayers don't pay for waste, fraud, and abuse. I yield back.
Mr. Smith is recognized to strike the last word.
Thank you, Mr. Chairman, for this opportunity. The bill, as it's called Providers and Payers Compete Act, it's obviously important. It's an important addition to this markup session today. If our healthcare system is to work for all patients, we need to ensure a level playing field and enact policies that allow for healthy competition. Unfortunately, it needs to be noted that over-consolidation can threaten local and regional healthcare markets, resulting in a less efficient, more costly outcome for those who live there. It is important for the Centers for Medicare and Medicaid Innovation, or CMMI, to take consolidation into account in their models. As many of you know, I have many additional concerns with how CMMI operates. From a lack of congressional accountability to shockingly low success rates in their model testing, it's clear more needs to be done. But in the meantime, this is a small but meaningful step to improve the CMMI model development and testing process. I will be voting in favor of this bill today and hope my colleagues will join me in working to strengthen the integrity and utility of CMMI through the creation of meaningful guardrails. I yield back the balance of my time.
Does anyone wish to strike the last word? Seeing none, we will move on to amendments. Are there any amendments to the amendment in the nature of a substitute? Seeing none, the question is on the adoption of the amendment in the nature of a substitute. All those in favor signify by saying aye. Aye. Those opposed say no. No. In the opinion of the chair, the ayes have it, and the amendment in the nature of a substitute is agreed to. I will now recognize Mr. Buchanan for the purpose of offering a motion.
Mr. Chairman, I move the committee favorably report H.R. 3284 as amended to the House of Representatives.
The question is on the motion to favorably report H.R. 3284 as amended to the House of Representatives. The clerk will call the roll.
Mr. Buchanan. Mr. Buchanan, yes. Mr. Smith of Nebraska. Mr. Smith of Nebraska, yes. Mr. Kelly. Mr. Kelly, yes. Mr. Schweikert. Mr. Schweikert, yes. Mr. LaHood. Mr. LaHood, yes. Dr. Winstrup. Dr. Winstrup, yes. Mr. Arrington. Dr. Ferguson. Dr. Ferguson, yes. Mr. Estes. Mr. Estes, yes. Mr. Smucker. Mr. Smucker, yes. Mr. Hearn. Mr. Hearn, yes. Mrs. Miller. Mrs. Miller, yes. Dr. Murphy. Dr. Murphy, yes. Mr. Kustoff. Mr. Kustoff, yes. Mr. Fitzpatrick. Mr. Fitzpatrick, yes. Mr. Stubbe. Ms. Tinney. Ms. Tinney, yes. Mrs. Fishbach. Mr. Moore. Mr. Moore, yes. Mrs. Steele. Mrs. Steele, yes. Ms. Van Dyne. Ms. Van Dyne, yes. Mr. Feenstra. Mr. Feenstra, yes. Ms. Maliotakis. Ms. Maliotakis, yes. Mr. Carey. Mr. Carey, yes. Mr. Neal. Mr. Neal, no. Mr. Doggett. Mr. Doggett, no. Mr. Thompson. Mr. Thompson, no. Mr. Larson. Mr. Larson, no. Mr. Blumenauer. Mr. Blumenauer, no. Mr. Pascrell. Mr. Pascrell, no. Mr. Davis. Mr. Davis, no. Ms. Sanchez. Ms. Sanchez, no. Mr. Higgins. Mr. Higgins, no. Ms. Sewell. Ms. Del Bene. Ms. Del Bene, no. Ms. Chu. Ms. Chu, no. Ms. Moore. Ms. Moore, no. Mr. Kildee. Mr. Kildee, no. Mr. Byer. Mr. Byer, no. Mr. Evans. Mr. Evans, no. Mr. Schneider. Mr. Schneider, no. Mr. Panetta. Mr. Panetta, no. Mr. Arrington. Mr. Stubbe. Mrs. Fishbach. Ms. Sewell. Chairman Smith.
Yes.
Chairman Smith, yes.
How is Mr. Stubbe recorded?
Mr. Stubbe is not recorded. Mr. Stubbe, yes.
Clerk will report the vote.
The ayes are 23, the noes are 17.
There being 23 ayes and 17 noes, the motion is agreed to, and H.R. 3284, as amended, is ordered favorably reported to the House. Without objection, I ask the staff be authorized to make technical and conforming changes to H.R. 3284, and that members have 2 additional days to file with the committee clerk supplemental, additional, dissenting, or minority views. There being no further business before the committee stands adjourned.